Hello, I'm
Hey,
Raj Gupta coming from Vanderbilt University, and I got Stuart Grant here from Chapel Hill. How are you, Stuart?
I
Well,
am great, Raj.
we're so excited. I can't tell you how excited we are. We are hosting the American Contingent Representation for World Day of Regional Anesthesia and Pain Medicine. We are so glad to be part of this incredible worldwide experience. This is started by our friends at the European Society of Regional Anesthesia and Pain Medicine. They are coordinating countries all over the planet. I think 6 continents are represented, and we've got programming from everywhere. And so we are doing our part today from the United States. We've got people all the way from California to the East Coast. We're going to be presenting in different time zones and different time slots, different types of sessions. I can't wait to show you guys everything that we have planned. And God help us if we have technical glitches, but we'll adapt. We'll adapt.
We've set ourselves up for success, I hope.
Hope so. Okay, so I have an ask, and I'm going to ask a few times. So for those people watching live, and we got a couple people logging in right now. Hopefully, we'll get some more soon. But as you're logging in, I want you to put in the comments 2 things. One, I want you to tell us where you're watching from, what city, what country, a little bit about yourself, whatever you want. Put something in there so we can get an idea of who's watching, and we'll see all these coming up. The second is if you have questions about what's being presented, put a question in the comment section of wherever you're watching, and we'll get that feedback. If it's appropriate to show the presenter, we'll show it. Otherwise, they'll be able to see it later and answer it on the website itself, on YouTube, Facebook, wherever you are. That we'll ask the presenters to go back and answer those questions after the fact. But
Yeah, they can get your chat comments at YouTube anytime. So we don't do it right now. We will log in. I see already. Imagine
already seeing,
Brussels, fantastic, and
yeah,
Canada.
yeah. Thank you for those people coming in. I mean, we're excited, and we want to see engagement from everywhere. So we're really excited. Pittsburgh, there we go. So um, keep putting those in there. We're going to be watching, and I'm excited to see how many different countries we can get represented.
Yeah.
We don't want to delay the start of this program. We've got a great presentation to kick this off with, but I want to do a couple of quick announcements, and I'm going to put a few things up here for you guys to see. We're going to be brief about this, so just bear with me. First thing is, again, we're so thankful to Ezra, to the whole team at Ezra for putting this together. This is the second year they've done it. It's already such a gangbuster success. We're really excited and happy to be part of this. And Ezra is eager to be showing off all of our skills in this. Second is that we've got a group that's doing a survey on pre-hospital use of peripheral regional anesthesia in emergency medicine. We've asked, as a courtesy to our Ezra hosts, that you guys participate in the survey. If you want to screenshot that QR code, you can go to the survey directly and participate in this. Again, if you're watching this later, you'll be able to see the QR code in the video afterwards.
Yeah, we're still working the recording, so please
Yeah.
click on that and help them out.
Thank you. Next things up. So we've got our 50th anniversary of Azra Pain Medicine coming up. Our meeting in the spring. This is in Orlando, Florida, from May 1st to the 3rd. It's coming up. It's a huge, huge deal. We're celebrating 50 years of the modern Azra Pain Medicine.
Yeah, I know I look old enough, Raj, but I wasn't actually at the first.
And we've got a great lineup. Vishal Upal is the program chair, and he's put together a fantastic program. I think you guys will love it. Please come. We still have early bird registration available. You save some money, get into your hotel discounted rates. Do that earlier. Don't wait. Don't procrastinate, because those things will go away, and then you just end up spending more money because we know you're coming anyway. So just be there, save some money, do it early, and then we can't wait to see you there.
Phenomenal program. Should be a great few days. What I love as much as the program as the social events. So
absolutely. Next up, we've got the point of care ultrasound course in September. Sign up for that, azra.com/POCUS. This is a very limited availability slots. These are small group sessions. So sign up early, otherwise it'll fill up.
The student teacher ratio on that is phenomenal. So if you really want to learn, get hands-on time, that's a great course.
Absolutely. Next up, our fall meeting. This is focused on chronic pain, interventional pain, but there's a lot of interesting stuff for acute pain and regional anesthesiologists as well, especially as we talk about transitional pain, neuromodulation, cryo analgesia, lots of things that intersect between the two. This is in Austin, Texas. We haven't done a meeting in Austin, Texas before. I've never been to Austin, so I'm excited to go to this meeting, November 13th through the 15th.
Yep.
Go to the meeting, azra.com/pain. You can find all the details. All right, we're back. And then you want to mention something, sneak peek for next year?
Yeah, next year, to synchronize with it'll be the third day. We're actually going to do an ASRA workshop. We're going to have a dissection and cadaver workshop. If you want to know the anatomy behind the blocks, we're actually going to have some limited spots where people can do the dissection with the faculty. But ASRA Ultrasound Workshop will be back for next year, third year's World Day, Regional Anesthesia and Pain Medicine. So that'll be coming up on ASRA's website in the next few weeks.
Awesome. So we want to get right into our programming. We've got a tight schedule, so we're going to keep everybody on time. Keep sending in the comments where you're listening from.
Yeah.
We really want to see that. We're already seeing so many countries. I'm excited to see everybody involved. Our first presenter this morning, I'm going to bring up Dr. Dan Shams. He's one of my colleagues here at Vanderbilt. Hey, Dan.
Hey, good morning, everybody. Thank you all for joining us. My name is Dan Shams, one of the faculty here at Vanderbilt University Medical Center in Nashville and the director of the acute pain service. Thank you all for joining us as I'm going to lead this off. I did a little switcheroo. Some things changed around. It was going to be a live demonstration, but I'm going to still cover the same things I kind of wanted to cover. It's unfortunately just going to be a little bit more of a PowerPoint show here.
No worries. We're eager to see what you got to present. What I'm going to do is I'm going to give you the stage. Stuart and I will come off the screen, and the show is yours.
Perfect. It should already be up if you have it.
You're good to go. We're seeing your presentation.
Oh, okay, perfect. You know, one of the things that's, well, I think it goes past it. Feel free to answer whenever you want, and I'll just talk a little bit. Yeah, you know, in the last couple of years, a couple blocks have come up. And I'm going to Tarantino this a little bit. The MTAPA and the EOI, or the external oblique intercostal block, that are hoping to address the lack of coverage that we've had in the kind of the upper left and upper right quadrants. And hopefully we are, you know, getting to the stage where those are starting to accrue a little bit more evidence and can become a little bit more widely used. I'm not seeing them come up, and it may be an access issue. I'm not sure. There we go. Perfect. A little bit spread out all across. You know, of the blocks that we have in place that people do utilize, you know, the rectus sheath doesn't tend to cover much more than the anterior abdominal wall. The OSTAP was supposed to be the answer to that, but may not be. And some of the other blocks, you know, might need too much volume to kind of cover that area. And I'm going to cover that here in just a second. Perfect. I'll take 5-ish responses here. Yeah, that's kind of what I expected, that most people have seen some here. Yeah, that's really the question of what have people been doing these. And it looks like, yeah, there is a good number of people that have at least seen or performed some of these newer blocks that we're talking about, the TAPA, the MTAPA, the EOI block. So kind of like I was hinting at, what are the targets that we're looking at? You know, when we're talking about the upper abdomen, we're talking about T5 through T10, both interiorly and laterally. And on every slide that I have a picture from, or that I'm quoting something, I will try to have a QR code if anyone is interested to pull those studies up right there. With that, that means that we're trying to cover both the anterior and lateral cutaneous branches of the intercostal nerves, and that's proven to be a little bit more difficult than people thought that it would be. And those are important for a lot of different surgeries that we do. It's for a lot of open cases, exploratory laparotomies. You obviously need to cover the midline incision there towards the top, in hepatic and biliary surgeries, particularly if they're doing any kind of chevron or hockey puck shaped incision. When we talk about splenectomies, which is the reverse of that, on the left side rather than the right, or subcostal nephrectomies, the area of coverage, or open cholecystectomies, the area coverage is not necessarily there. And that remains true for things like lap choles, robotic gastric surgeries, bariatric surgeries, same thing with nephrectomies, that maybe we just haven't been covering them as well as we could be. And the problem is something that, again, I already mentioned. Are you getting the anterior cutaneous branches, or are you getting the lateral? Very unlikely that you've been getting both in the blocks that we've had before us. So what are those blocks? The seasoned vets, right? The ones that have been around for a little bit. The first is the rectus sheath. It's been around since 1899. That was the first time that it was actually described. And it targets the anterior cutaneous branches of the intercostal nerves. You're injecting between the rectus abdominis muscle and the posterior rectus sheath. But it just does not cover the lateral cutaneous branches. Great for something like an XLAP, not so great for anything that's coming out towards the outside or more lateral aspect of the upper abdomen. One answer to that, and I'm not going to talk about the TAP because I think most of us will agree that the TAP is really covering the infraumbilical abdomen, was the oblique subcostal transverse abdominis plane block, or the OSTAP. A variant of the TAP block done higher up along the costal margin, injecting between the RA and the TA. However, a dermatomal study that was done showed that you don't necessarily always get those lateral cutaneous branches, even if you do follow the traditional way that this was described by Habar, which is essentially chasing that almost as far lateral as you can get. And in this, I also want to give a quick shout out to a article called The Anatomical Basis of Fascial Plane Blocks by Dr. Chin and El Shirkawi from 2021. That's fantastic. If anyone hasn't read it, it really helps to explain the method of the madness behind all these plane blocks that are coming out and will continue to come out. Next, we've kind of come to this block, the quadratus lumborum block, that while certainly not as established as something like a rectus sheath or a TAP, has been around for a little bit now, and has multiple approaches described. The QL1, now trying to be termed the lateral QL, injecting between the lateral border of the QL muscle and the transversus abdominis aponeurosis, which is the picture on the left. So you can see right there on the edge. The QL2, which is the posterior QL, injecting on the posterior side of the QL muscle, which is this injection right here. And the anterior QL, which is injecting between the QL and the psoas muscle, which is the second photo that can be visualized here. As the photo on the left kind of shows you, the QL1 or the lateral QL is really just very similar to a TAP block, whereas the QL3 or the anterior QL is the one that's starting to look a little bit more different. However, there was a study out of South Korea, I believe, that showed that despite increasing volume, so this is 20 cc's, 30 cc's, and 40 cc's, you really don't get those anterior branches particularly high up in kind of the T5, 6, 7 range. No matter what you do, you're just not getting that anterior coverage. You might start to get some of that subcostal coverage, but you're losing the anterior cutaneous branches. And then finally, the erector spinae, which for a lot of people wouldn't want to call it a seasoned vet, although by now it's almost been out and about for about 10 years. Injecting between the transversus process and the ESP muscle. You might get good coverage here depending on where you do it, but it requires it to be preoperatively because you can't do it supine. So in come the new kids on the block. We've got two blocks that have been coming up and around the last 3 to 5 years. One is the thoracoabdominal nerve block through the perichondrial approach, a little bit of a mouthful, or the TAPA block, and then the modified version, which essentially takes out the first injection. First described in 1819, 2 injections at the costochondral angle, and I've got photos coming up in just a second. One above the costal cartilage, one deep to the TA muscle origin, or the modified TAPA, which is just the deep injection. This looks something like this, placing a linear probe in the sagittal plane, identifying the 10th rib, identifying your essentially TAP plane muscles, injecting underneath that 10th costal cartilage and seeing that spread. So bringing your needle in something like this should be your view. And then that injection spreads in this direction. The initial claim was that you got about T5 through T6 lateral cutaneous branches and then T7 through 12, the anterior lateral cutaneous coverage. The dye study seemed to show a little bit less than that when you inject less, but equivalent to that when you inject a higher volume, which is what most of us would do in a plain block. Plain blocks are volume driven. The dermatome study showed the same level of spread, but more consistently within T8 to T10 when you inject at the T10 level. But there are multiple case reports that show decreased pain scores, opioid consumption across the surgeries that we just talked about. Cholecystectomies, and then compared to the OSTAP showed no difference, which makes sense if you think about where that block is done, which is almost in the same place. Should give you very similar coverage. The other block that's been making the rounds is the external oblique intercostal block, first described by Dr. El-Sharkawi, 21. Single injection in the sagittal plane, this a little bit higher, the level of the sixth rib of the midclavicular line, and tries to answer that same question. Can we get the anterior and lateral cutaneous branches? The description is pretty straightforward. Identify the sixth rib, however you choose. Rotate the transducer a little bit so that the cranial end is medial. And then identify the external oblique muscles, the intercostal muscles, your ribs, and your pleura. And then you want to advance in this situation rather than caudal to cranial to caudal, in between the external oblique muscle and the intercostal muscles. So it'll look something like this, and that injection would go right into that plane. Now, I've actually stolen this video from Jeff Gadsden's wonderful regional anesthesia acute pain medicine video series. So if you have a chance to go there, which you should have it right there, please do. No sound associated with it, but he's kind of showing where he's going to end up, and it's only about 10-15 seconds here on this video. You can see your external oblique muscles, your intercostal muscles, your pleura deep, and he's advancing slowly in here, going to get into that plane, start to hydrodissect, and then try to chase that all the way across to that rib, ideally trying to get that local anesthetic spreading above, which you should see here just shortly. There he goes. So what's the evidence there? Essentially same level of coverage, right? T6 through T9 with the anterior cutaneous, T6 through T10 lateral cutaneous. The dye study proved the same, multiple case reports. And then finally, we're starting to see some RCTs come out, right? Benefits in sleeve gastrectomy, open abdominal surgeries, laparoscopic cholecystectomies, and as effective as an OSTAP in supraumbilical surgeries in one RCT, with another RCT showing a benefit over the OSTAP for lap gastrectomies. Now, then the question is there a head-to-head here? There's one. There's one RCT looking at EOA versus MTAPA and lap sleeve gastrectomies, found similar effectiveness. So what's the takeaway? We may be entering the time when we're introducing newer blocks. What's the benefit? We don't know yet. That's really the biggest takeaway. These blocks seem to make sense to target an area that we hadn't been targeting as well as we could have before, but we need further evidence to show it. It seems like the evidence is pointing in that direction. Let's still wait and see. Did I time that? I got it.
You got it. That's great. Awesome. Thanks, Dan. Yeah, this is, it's in retrospect, it's always so obvious that it's right there in front of you that we got to attack those nerves. But, until somebody brilliant like Dr. El-Sharkawi just kind of points it out, it doesn't make sense. And I say this knowing that Hisham's actually listening right now because I can see him.
Yeah. Pretty much every article that I put into that paper is written by someone who's going to be on this call a little bit later.
Yeah. We're lucky to have these people in our circle. So Dan, your second topic that you wanted to talk about was lidocaine infusions. And we have a variety of different approaches to lidocaine infusions across the country. Some places won't touch them, and some places are using them quite liberally. I know our personal story here. I wanted to get your 2 cents on, kind of what our experience on lidocaine infusions have been here. Is it all voodoo, or do you think there's something actually that people should pursue?
Yeah, I mean, and that's a great question, Raj. That's why I wanted to have that talk with you. I think we were lucky enough to be one of the groups that was part of UT Knoxville's first, regional anesthesia acute pain medicine fellow multi-institutional journal club. And when we presented at one of them, one of the discussions that came up from Vanderbilt was that we do lidocaine drips a lot. We have it in a lot of our ERAP protocols. And we certainly seem to see the benefits here. But when you take a step back and look at the meta-analyses, it's not necessarily supporting that quite as much, right? There's a Cochrane review, but although the Cochrane review basically comes back and says there might be some benefit, but we need larger scale RCTs to really show it. You know, there are individual RCTs that are showing benefit in certain subpopulations, primarily abdominal surgeries, and then others that don't show nearly as much, like lap nephrectomy, seem to not have as much evidence for them as open abdominal surgeries do.
So do you guys keep them running in the floor or just running
Yeah,
in the bar?
Absolutely. So that's, you know, where I came from, we did not. So I trained at Rush University Medical Center in Chicago. And then when I came here, so it was definitely news to me to keep it going. But that's where most of the evidence seems to point to, is that you really get that benefit if you continue on. So here at Vanderbilt, you know, we have a robust acute pain service and perioperative medical consult service. And we follow these patients daily. They're charted on every 4 hours by the nurses to see if they're having any side effects from the lidocaine infusions. So we believe it's safe to keep it going. We keep it going 24 hours. And if patients are still having significant pain and we think it's worthwhile, we continue for another 24, but it's a case-by-case basis.
Okay. And can I ask, if somebody who's in a hospital where we don't carry them going in the floor, have you had any cases toxicity? And if you do, is there any theme how it presents early? Start doing this.
Yeah, they're just like anywhere else. When you use enough of it, absolutely cases do come up. The cases that have come up have been inadvertent administration too fast. Most of the time it is the lighter end of things, right? So and that's actually one of the main reasons that we stopped the infusion early is patients starting to complain of double vision, tinnitus, or, you know, metallic taste in the mouth. Those are, we often see that happen, and we do stop it early when we start to see those side effects.
Okay. I just wonder, people can leave in the comments, who does and who doesn't run them in the floor afterwards. I'd love to see some comments about that with lidocaine infusions.
Yeah, we had I was part of the conversations with our pharmacy and some of our other medical services when we were trying to first introduce this, and the fear was quite large. Oh my God, I can't believe you guys are going to do this on the floor. And so we had to kind of get people comfortable with this concept and put a lot of layers of safety in. So that's dosage safety, who can prescribe it, safety. So we made sure that we had lipid emulsion available on every floor where we give lidocaine infusions that are available quickly. We started educating the nurses about local anesthetic toxicity and the symptoms. Truthfully, our experience has been, you know, there's the not so fun side effect of neurologic sequelae, usually mild, like Dan talks about, but of course seizures are the worst case scenario. And then there's the one that's more scary, which is arrhythmias and cardiac problems. And honestly, and Dan, you can correct me if I'm wrong, we've seen very, very little of the cardiac. Very few. I mean, not even ectopy or anything like that. In fact, the only symptom I've seen really from a cardiac perspective is occasional bradycardia. And I don't see that very often. Most of the symptoms are neurologic.
Are there any conduction blockers, like if somebody's on flecainide, if somebody's on a high dose calcium channel blocker, you say no thank you? Is that in your criteria?
That's exactly right. So if we have someone with, you know, new onset arrhythmias, we stay away from it. If we have someone on things like flecainide, sotalol, antiarrhythmics, we stay away from it. If they have known uncontrolled seizures, we stay away from it. All those basic safety things you would expect. But I'd say probably 85 to 90% of the patients that come in on any of our colorectal services or any of our other ERAS services who don't get an epidural get lidocaine for 12 to 24 hours. And not only do they get lidocaine, most of them also get truncal blocks in the OR. And I know that's generally something that's considered to be not as safe, but just in the same vein as lidocaine infusions on the floor, we have not seen the issues.
Yeah. So, I mean, and then the other thing is that we do have some titration flexibility. So we give, you know, different doses, 1 milligram per minute, 1.5, 2 milligrams. So we have a little bit of adjustment there. And then we are quick to shut it off. If there's any concern, just shut it off and it's gone. And it goes away pretty quickly too.
Yeah.
So yeah, it takes layers of protections, layers of monitoring, but I find it to be a very potent tool in my armamentarium. I mean, literally I was on rounds this morning and I have at least 4 patients on lidocaine infusions this morning, some of them for enhanced recovery protocols, but some of them for trauma.
Mhm.
I mean, we use it quite frequently for trauma patients, multi injury trauma patients, where a single block is not going to serve them properly. And so we use lidocaine infusions for that systemic effects. Patients can tell you, oh, I noticed when the lidocaine infusion stopped.
Mm-hmm. Or when it started.
When it started.
We have plenty of patients. We're level 1 trauma, tertiary coronary care referral center. We see a lot of polytrauma patients, like Raj was saying, with multiple rib fractures, multiple other injuries. And sometimes someone's not available immediately to do something procedurally. And so we will often temporize them with lidocaine. And I think we do less than we used to because patients do so well with the infusions and the multimodals.
Wow. I've got so many questions to this. We'll only give so much time, but if you're sitting at home and thinking, wow, this interests me, Raj and Dan are at Vanderbilt Hospital, Tennessee. Come and meet them at the Azure Spring meeting, or contact them at Vanderbilt, get them come and do a grand rounds. I think when you talk about here the non-technical skills, talking to pharmacy, talking to nursing leadership, how you going from zero to getting these things in. Mm-hmm. There's a lot that's not in the talk, there's not in the presentation. I'm sure folks would love to chat to you more about those details.
And departmentally, one of the things that we do strategically is that we've placed people in our department through committees all over the hospital that are non-anesthesia committees, so that when initiatives like this come up, we can speak internally instead of externally to those committees. And so that we find helps a lot in making some of these things possible. You have to be invested in the system so that when you want to change the system, you're already there.
Absolutely. And I mean, Raj was part of the P&T committee here for a long period of time. And the previous head of the acute pain division, Matt McAvoy, also instrumental in making sure that we have those safeguards in place so that the people directly taking care of the patients on the floor, the nurses, the primary team, feel comfortable with the patients being out there. I also was lucky enough to come in after all this had been settled. So I got to benefit from the fact that everyone was already doing it, which has really made a big difference in our care.
Yeah, it was about a 2 to 3 year process getting it approved. So it wasn't like an overnight thing. So what dose of lidocaine infusion? Let's finish with this. What dose of lidocaine infusion do you use, Dan?
Yeah, so we actually vary it by weight. So we have weight-based dosing post-operatively. Intraoperatively, we use a 1.5 mg per kg bolus plus a 2 microminute drip. But post-operatively, that's based off of weight. So I think if it's less than 70 kilos, it's 1. If it's 70 to 100, it's 1.5. And if it's greater than 100 kilos, it's 2.
So it's not weight-based, it's weight stratified.
Weight stratified, correct, yes.
Yeah.
And we had discussed, possibly dropping that top level, but we just haven't seen enough of the side effects to say. I think the international consensus was nothing higher than 1.5 on the floors for infusions, but we just haven't had we haven't seen the need to drop that yet.
Mm-hmm.
Well, Dan, thank you so much for talking about some creative approaches to abdominal blocks, something that I think that everybody should include into their regimen. And then also talking about lidocaine infusions, which I know a lot of places are not using like we use here at Vanderbilt. We'd love to talk to any of you. Dan's deep in it here at Vanderbilt, so he can tell you all the details about what makes it work, where your pitfalls are, and then how you make it succeed in the institution. So thank you, Dan. Really appreciate you.
Yeah, thank you for having me on. I'm looking forward to the rest of this.
All right. Take care. All right, Stuart, that's a great kickoff for this presentation. Dan did an awesome job. Some interesting topics. We got people from all over: Memphis, Greece, Peru, Nova Scotia, London, London, Ontario, not London, England, London, Ontario, Bangladesh, Pakistan. I mean, really getting a diverse group of people listening in, and I'm sure they've got a lot of questions. Yeah, this is definitely World Day. This is great. For people who are just joining us, tell us who you are in the comments, where you're coming from. If you have questions about the presentations, we'll try to answer some of them in real time. If not, we'll ask the presenters to go to these comments and maybe answer some of the questions after the fact. Just as a reminder, I'm going to kind of plug our meeting coming up in the spring. We're going to have a fantastic 50th anniversary of the American Society of Regional Anesthesia and Pain Medicine in Orlando, Florida. We would love to have all of you guys join us. It's going to be a great meeting, and we don't want you to miss out to this awesome experience. Great people, all these people that you're going to listen to today, they're going to have something to say. All right, should we bring up our next group?
Yes, let's.
All right, I see them teed up here. Look at this bunch here. Hey, what's up? This is Stanford.
Hey, thanks for having us. Yeah, welcome. It's welcome to the West Coast of the United States, where it's 8:30 in the morning. To everyone, I appreciate everyone joining from all over the world. So thanks for organizing, Raj and Stu.
Yeah, so we're excited to hear what you guys have to say. We got a couple people in the back listening in as well. Why don't you do quick intros of who everybody is, and then I'm going to put you guys on the big screen and let you guys start the conversation.
That's perfect. So thanks. Thank you, everybody. I'll introduce myself first, Ed Mariano, professor at Stanford, and I'm chief of anesthesiology at our Veterans Affairs Palo Alto Healthcare System, where we're streaming live now from our conference room. Okay.
Good morning, everyone. My name is Miriam Sarwari. I am a clinical assistant professor here at Stanford, and I also serve as the associate program director for the Regional Anesthesia and Acute Pain Medicine Fellowship here.
Good morning. I'm Jody Lang. I'm the program director for our Regional Anesthesia Acute Pain Medicine Fellowship at Stanford, and I'm the director of acute pain, of regional and acute pain here at the VA in Palo Alto as well. And we have some of our team hanging out and having breakfast with us at the same time.
Hey, team.
Hi, team.
Well, thank you. We appreciate you inviting us to be part of the program. I mean,
of course. Great. And we've got people all over the world listening to you guys. So I'm going to pop you guys on the big screen and let you take it over from here.
Perfect. Thank you. So what we decided to do, we wanted to do something a little bit different, for this portion of the live stream session. So rather than just pummeling you with more PowerPoint slides, we thought we'd just have a question and answer panel discussion, because I think this particular topic, in terms of education and regional anesthesia, just keeps evolving. And as we all know, we're so passionate about regional anesthesia education that we're here in California on the Saturday morning, just to talk to you a little bit about what's new in terms of education regional. So what we thought we'd do is I would moderate a Q&A, and then we're going to open it up. If you have any specific questions, please put them in the chat, and then Stu and Raj will be able to field those with us. We're going to have the next now 27 minutes with you all until we hand it off to our next group. And so I'm going to start my first question for Miriam. And there are so many blocks these days. I think now that we have ultrasound, there is no fascial plane that's not deserving of local anesthetic. If you were to go back in time, if you were a resident in anesthesiology right now, with the plan to go into more of a general practice, which blocks would you recommend learning as your core set of blocks that you think every anesthesiologist should know?
That's a great question, especially considering that the requirements for regional anesthesia and graduating as a resident are so broad here in the States. So if I was a graduating resident, one of the blocks that I would really focus on is the adductor canal, peripheral nerve block. And the reason I say this is I've done a fair time at the outpatient surgery centers, and one of the barriers to discharge is often postoperative pain control. And one of the biggest culprits usually is our knee surgeries. And so oftentimes that adductor canal comes in handy in getting patients a little bit more comfortable and having the ability to actually send them home the same day. So that's one of the ones that I have used often to rescue. And I think also it's a very manageable one to do during your residency, get a lot of the numbers in and really feel comfortable with. Other than that, I would say one of the upper extremity blocks, whether it be the supraclavicular or the infraclavicular, oftentimes residents will choose the supraclavicular because it is a little bit easier to do and less deep. And the reason I would choose that one is it does a great job of providing surgical anesthesia. And so it will allow the resident to increase kind of their toolbox of anesthetic options, especially in this day and age where our patient population is getting sicker. It's nice to be able to do a regional MAC and avoid general. So either one of those is a great one to kind of hone in your skills during residency. And then lastly, since you've already kind of managed the adductor, adding the POP for the popliteal peripheral nerve block for the same reasons of being able to offer a surgical block of the lower extremity, I think would be great. So it's really hard to just choose, a handful of blocks. Obviously, I think the interscaling is great for shoulder procedures, etc. But if I was to only choose 3, those are probably the 3 I would choose.
Those are some key ones. I mean, I think that I think you really hit on an important topic, which is, what is going to get you and your patient out of trouble in the middle of the night when you're in the middle of nowhere, and some of those blocks of the distal extremities that actually help you avoid general anesthesia are really key. I think it's also, we've been learning so much more about which patients and which procedures really deserve or really require much better pain management. And I think you mentioned shoulder surgery. I think one exciting aspect, I think, of the supraclavicular is that if you master the supraclavicular, really it's a continuum of supraclavicular to interscalene, and that allows you to do almost any type of regional block for upper extremity surgery. Those are great. Thank you. I'm going to ask Jody the next question. So we have, the reason I'm asking Jody this question is because not only is she our program director at Stanford, but she's also one of 2 counselors that represents the specialty of regional anesthesiology and acute pain medicine in the Association of Anesthesiology Specialty Program Directors, which is a national organization that's dedicated to fellowship training in all the subspecialty areas. And so we're fortunate to have Jody as one of our 2 counselors representing our specialty on a national stage. So I'm going to ask you specifically about changes in the fellowship. Because I think we've seen a lot of advancement in fellowship training, or what we consider advanced training in regional anesthesia beyond residency. What do you think are the most significant advancements? If you had to pick a couple of things that the fellowship programs or the program directors or the group nationwide of fellowships have done in the last couple of years, what do you think have been those huge milestones?
Like for regional anesthesia fellowships in particular, excuse me. It's actually been really fun and eye-opening to be part of the Association of Subspecialty Program Directors, because you do get to hear what's going on. I mean, we all just run these parallel lives, and program directors for pediatrics, anesthesia, and cardiac anesthesia, et cetera. And I think we all are on the same track, parallel tracks. It's just that some programs have done things in different orders and maybe decades sooner than we have. So just in my short time as a regional anesthesiologist, I would say one of the biggest changes for us as a specialty is that we've gotten organized, in an official capacity. We're so lucky to have had these pioneers like Dr. Mariano and a lot of the folks at HSS, for example, who began regional anesthesia programs, decades ago. And I'm told that the meetings used to look like 8 people sitting around a table at ASRA having breakfast, which is awesome. But now there's 80-ish programs in the US for regional anesthesia fellowship. So we've just had to get organized. And so even just in the last year we've actually we're officially incorporating an organization, Regional Anesthesia Fellowship Directors Association, which we are referring to as RAFTA, and has been kindly sponsored and supported by ASRA, since we're joint organizations. And this allows us to be represented at a national level and have a voice as a group of fellowship program directors who have a common goal of making sure that we have, appropriate educational steps for all of our fellows. And then we can be represented as a group, in whatever way is needed. For example, if we need a voice with the ACGME, then now we can speak as an organization rather than as individuals. And so that gives us a lot of weight and power, I would say. So that's actually brand new. We're still in the process of putting final touches on and starting to collect dues for the first time. It's very exciting. That's a big change that's happened on the national level. Another one is just that some things that have happened in the last year. We're part of the match now. We, at least in the US, we have a match system, which from the fellowship program director standpoint, thank goodness, it's so much better than the previous. It was becoming a little bit of a Wild West kind of situation of interviews, offers, etc. And the timing was creeping earlier and earlier. With a match process, again, we can all be joined and have this sort of common common goals. We can all have like a common set of rules that everybody follows. And then it's just like it's a very civilized process for both program directors and for applicants who want to be a part of the system. So that's been really great.
For our international viewers, who are probably used to just applying to individual programs, that's how it used to be in the United States. And as you mentioned, we have so many programs. You can imagine just how laborious, especially with the different timelines, just having applicants apply to this program all across the United States. I mean, just within our country, we have a 3-hour time difference. Not to mention travel in the days of not doing when we used to do all in-person interviews. What does the match look like, and what does that timeline look like?
Yeah, well, Ed, applications are open now. Applications just opened January 1st, and we try to make it a pretty generous timeline. So applications open in January, and match day is in June. And in between that, it's still just a really open and flexible schedule. So every program can sort of interview when they want. Many programs interview on a rolling basis, like throughout, from basically February through May. Programs and applicants have to submit sort of a rank list of their preferences, preferred programs, preferred applicants, to the match institution in June. And then a week or so later is match day, which is, like an actual notification time when everybody finds out, like,
here's where you're going.
Gifts, yeah, where you're going. So very similar to the, at least in the US, it's similar to the match process for residency. It's just a different organization that we use, but it's the same concept.
Mm-hmm. Well, I'm going to throw one out there for you just because I think that, we're obviously all biased in terms of how awesome regional anesthesia is. And anyone who's viewing this on the weekend is also in that same boat of people who love regional anesthesia. Yeah. So if you're a resident and you're thinking about, well, should I do a fellowship? Yeah, how do you differentiate the training goals and curriculum of a fellow versus the basic regional anesthesia training that we gear towards residents on their core rotation? What is the difference? Why would someone choose to do a fellowship?
Yeah, and it's a choice. There's a lot of choices that are available to CA2, CA3s these days going out into the world. I guess it depends on where you see your career going and what level of expertise you would like to have going out into the world. So certainly, folks going out into like a private group who, maybe you're planning on going into private practice, but you want to be able to be like a go-to person for acute pain or for regional anesthesia. You want to have this like skill set you can offer your colleagues. You can offer surgical centers. Some folks aren't able to go into like ortho centers right away if they join private groups, but like if you have this skill set, maybe you're sort of welcomed into these extra locations, and you can collaborate with surgeons. You can collaborate with folks running operating room scheduling. This is the kind of level of training that our fellows are getting. I always say our fellows are like folks who go into regional anesthesiology as a fellow, they're probably already really good at blocks, right? You're like, I'm good at this, I want to be better, great. Within 2 months, they're outstanding. They're going to be outstanding at nerve blocks. And like, if you want to be super good at nerve blocks, that's awesome. But there's so much more to the fellowship. And like the rest of it is about like understanding operating room functioning from like taking a step back and understanding the bigger picture of things, and how can we incorporate regional anesthesia into this system where it doesn't exist, or how can we better incorporate it where it's not working? If we have to start a new block, should we start it as a pre-op block? Should we start it as a PACU rescue block? How do I approach surgeons about new ideas? How should they approach our service about questions or new ideas? So it's a lot of training actually in like collaboration and planning. And then there's also like, I guess the more obvious training of everyone's going to know, everyone who graduates from an anesthesiology residency should be really good at supraclavs, adductors, popliteals, et cetera. But like, there's a lot of like filling in the gaps of the more complicated, nuanced blocks, and like fellowship, our fellowship, so many fellowships are all about the nuance, being really good at like understanding exactly what's needed for a patient and exactly what we should do, and just being like very skilled and like having some like finesse with the block that you're choosing and why. I think that's, it's another level. It's a new level of expertise. Yeah.
I love that. I love the idea of just like forming these using that year to really develop, what will be the expert consultant physician. It's amazing. But, eventually, like, even if you choose to do a fellowship, like, all good things come to an end. So, training has to stop sometime, and we all have to get real jobs and go into the world. So I'm going to ask Miriam, since Miriam is one of our superstar early career regional anesthesiologists. She actually was recognized by the California Society of Anesthesiologists with the President's Impact Award as a rising star. So just to make sure that you get due credit for it. What do you think? I mean, even after you are well trained, so you completed a very competitive and rigorous residency program in anesthesiology at UCLA. You completed our fellowship in regional anesthesiology and acute pain medicine here at Stanford. And now, like, in the early years of your career, what have you foreseen as some of the biggest challenges in making that transition to practice?
That is a great question. So as a fellow, getting ready for graduation, the greatest anxiety for me at the time came for supervising, because I was going to stay at an academic institution. I thought the hardest part would be supervising residents who've never held a 2E before, going in next to the jugular for internal healing. But to be honest, that came rather quickly. And some of the bigger challenges that come up as an attending are more kind of the clinical production pressure issues. So mainly making sure that I'm giving good teaching while ensuring the block is not delaying the case and causing frustrations with the surgical team, et cetera. So balancing teaching and then making sure we don't cause delays. The other thing, as I mentioned, at the outpatient surgery center, that became, I very quickly realized, ensuring that your block doesn't fail. As a resident and a fellow, the buck didn't really end on you. It was more of your kind of attending's issue if it didn't work. But now you're all of a sudden the attending, and especially for cases for individuals who really need a block to be able to get surgery done, and it doesn't work. There's a stress there. So those are the things, especially when you're not necessarily always the one needling and you're working with trainees who are new at this, trying to find a balance of encouraging growth, encouraging them to improve their skill set while ensuring a proper block for the patient and not delaying the room. I would say that's one of the biggest challenges, kind of keeping all those things together. But what I will say, going back to the prior question, one of the great things of the formalization of the fellowship in general, and I think one of the great things that differ fellows from residents, is one of the key things I walked away with in fellowship was really a set of leadership skills that has come in handy throughout my career thus far. And a lot of the things I talked about, whether it's a failed block or a delayed case, those skill sets help you kind of mitigate and talk to the rest of the team, whether it's your surgical colleagues or anesthesia colleagues. So I think one of the greatest takeaways of regional fellowship has been that skill set of knowing how to maneuver some of these difficult situations.
So what do you do? So I think this is a question for both of you, and start with Jody, and then Miriam, I want you to chime in. Because the learning never stops. So I try to think about, we all say, well, back when. So back when I was a resident, we didn't learn ultrasound. So I'd say, like, the biggest evolution in my postgraduate learning was learning how to use an ultrasound. But one of the challenges I think that we have today is there's almost like too many resources for education. Almost to the point where something makes it very difficult to choose. So, what would you say in terms of learning tools for the practicing anesthesiologist? So, post training, what are some sources that you tend to use and recommend? Use yourself and also recommend to graduates and colleagues.
I mean, I'm like, this is going to sound like a sales pitch, but ASRA, ASRA is like the biggest, it's just the biggest meeting of all of us across the country every year. And like, if I want to know what the latest, like what is the cutting edge thing that's happening right now? What is the latest, like, hot block that's happening? ASRA, I often hear about it first at ASRA. This is like, my caveat is I'm not like huge on the social media. And so Ed's answer would be different from mine. But for me, I'm like, I want to see it in person. I want to see it in a workshop. I want to see how people are using it. I want to hear talks about how people are using like the latest block. I learn a lot at ASRA every year. It's been really, I don't know, it's been a great organization for me, and it's been great to like just get together and see what people are doing. On top of like RAPM, other journals, just trying to stay up to date on literature in general. We're lucky to work in a teaching institution, so like even like our fellows will roll in from if I'm doing clinical work here at the VA, our fellows rotate in from Stanford, and they'll be like, at Stanford we do blah blah blah, and I'm like, cool, let's do that. What paper did they use? Let's open it up and like let's check it out. So often it's just like collaboration with our immediate colleagues right here too. I'm always learning a lot from whoever I work with.
Mary, what resources do you use to stay up to date?
That's a great question. I think for me, the most important part is finding resources that get incorporated into my day-to-day. As much as I would love to say that I can sit down, once a week or once a month and, crack open a book, things that work well for me. I agree. Whenever I get either the ASA Monitor or RAPM journals, it's an easy thing that's on the table, whether you're, having breakfast on the weekend or something to quickly peruse. Going back to what Jody said, being at an academic institution exposes you without you even knowing. We have monthly journal clubs that the residents and fellows present at, and that we help them review articles for. So that keeps you up to date. And then as well as, being asked to do lectures. So you're kind of
that is a great point.
Required, if you will, to kind of do a deeper dive of the literature, and then also the endless questions, which I love, force you to be like, you know what, let me double check and realize that things have changed since when you trained. And then for me personally, I have a little bit of a commute coming into work, so podcasts work really well. And there's a lot of different podcasts available through ASRA has them available. I know ACRAC, time I was studying for boards, and they also have a regional section as well. So whatever you can incorporate into your kind of daily, weekly life, I think is the best way to stay up to date.
Yeah, I do the same. I mean, I would say I like a mix of media when I'm trying to keep up to date. So I love the socials. So I still use X, formerly Twitter, because there's just so much engagement worldwide. So which makes it very hard to leave that platform, because there are so many regional anesthesiologists that are involved, and will post, share articles, comment on things, engage in conversation. It helps me not just know what people are talking about and what they're doing, but also maybe which topics we may want to investigate further. So it also kind of feeds into my research process, which I think is a lot. I love listening to the podcast too. I'll give like a quick shout out to Block It Like It's Hot, which is our friends Amit Pawa and Jeff Gadsden. Entertaining yet educational. It's like, edutainment. So I like that one too. But I do think that there's a lot to be said about networking, and the meetings for me, I know it evolves over time, but I still love going to live meetings. I love going to ASRA. I love going to Ezra. And the fact that you can interact with people in person, and where you share this real passion for pain management and improving outcomes for patients, and you realize that the world's really not that big, and the fact that you're thinking about similar things, thousands of miles away, I think is very powerful. I'm going to ask you as a quick question as we kind of get close to wrapping up, and I'm hoping that our hosts will join in with us on this too. So Raj and Stu, if you're kind of listening in the background, we're going to pull you back in, because I would like to know, I'm going to ask Miriam and Jody, but where do you see the future going? Where is education headed? What's on the horizon in the next few years? What are some hot things? And I want to hear that from Raj and Stu as well.
So separately from ACGME guidelines for fellowship, there are fellowship guidelines that have been published, but our last published fellowship guidelines for regional anesthesia and acute pain medicine were like 10 years ago. And so I think coming down in the coming year or so, there's a group of folks talking about updating these guidelines, not as like strict, numbers and procedures guidelines like you would see with the ACGME, but more just like this sort of question, like an umbrella of like, what should we be focusing on? What should we be teaching? And what do we see coming down? So, we were actually just talking about this before we went live, but, treatments for opioid use disorder, treatments for chronic pain. We've been doing a lot of buprenorphine inductions and prescriptions here at the VA Palo Alto. And I think that type of practice, even just for us here, has been a real game changer in terms of what we can do for patients with opioid use disorder. I think treatments like that, working with buprenorphine, working with methadone, working with other, maybe slightly safer opioid treatment options for patients in the long term should be a focus, can be a focus, and maybe should be a focus for fellowships in the future.
Miriam?
I think technology is not only coming, it's here. So a lot of the advancements I see are related to kind of software and technologies. One of the things that we have started to use at Stanford, we have the ability to record the blocks we do with our residents and fellows real time. And so going back to some of the production pressures I talked about, we may not have time that moment to review things, but once we find a quiet moment, we replay the videos and we can kind of talk more about technique, anatomy, et cetera. And it has really improved our teaching with our trainees, especially when the schedule gets a little busy. And, at the past ASA meetings, I've had the opportunity to see new technologies with ultrasound and needling. Some software allows residents and fellows to see highlighted anatomy, which sometimes, again, when you have awake patients, it's hard to do as much teaching as you would like to, but when you have colored, configurations on the ultrasound screen, it helps. So I think technology is going to kind of change the world of regional.
Perfect. I'm going to throw that right back because I think we're talking about AI. Raj, where do you see the future of AI in education and regional anesthesia?
Yeah, I kind of want to combine both of the answers that you guys gave already. There's two things I think that are really going to be important. One, Ed, you alluded to AI, and paired into that, I think, is augmented reality. I think that the ability for information to be more accessible to us in real time, whether it's the imaging, an atlas, instructional video, even a helper. I did a demo with our friend James Bonus where we actually had 2 Vision Pro headsets, and I had him kind of call in and he could see what I was seeing and help me through a block as a sort of educational instructor. And he was in London and I'm here in Tennessee, and we were able to kind of create this dynamic experience. So I think that this world of extended reality is going to allow us to be more nimble. And we're actually behind a lot of what the surgeons are doing. They're doing a lot more advanced work in this than we are, and I think we can catch up. The other thing I was going to mention is the intersection between chronic pain and acute pain. And Jody mentioned the medications, but also the procedures. So we're going to have a talk coming up later today about neuromodulation and where it fits into potentially acute pain, cryoanalgesia, and what we can do that is beyond our local anesthetics. And there's new pharmaceuticals coming up that are going to change the equation as well.
How about you, Stu? Yeah, where do you see technology going?
Yeah,
on the front end.
Yeah, I think there's, on the AI topic, I use open evidence. I don't know if you guys are using that for keeping up to date. There's like 50,000 publications a year in anesthesiology alone. So trying to keep up to date with, what's new, what's current, and what the best evidence is. I think we'll have these things on our phone. So just-in-time education. And I also think along another AI is when I do, as a teacher, I'm trying to create slides, documents, like creating questions for education, like open evidence. I'll create a list of 10 topics for NOR education for residents, for fellows. So I think us as educators will get help, let alone, evidence, what's the best block to do before you start. So I think there's going to be hopefully a lot of help for us coming up. And just to tailor in, Jody mentioned some of these new educational problems and tasks. Azure's got fantastic guidelines on the website, the website for how to look after patients with buprenorphine, how to look after patients with opioid use disorder. So please go to Azure. The guidelines are free. There's much more information on the website for members as well.
That's right. Raj, any questions out in the field?
So we had one question earlier that was specific. If you're coming from a different country, the question was, I'm from South America. Which country is the best in order to do the regional anesthesia fellowship? I think we're a little biased, but maybe we can reframe the question is, how does somebody from South America do a fellowship in the States? Do you have any ideas on that?
Yeah, that's a great question. Actually, Jody might be able to go over this a little bit better because there are different, depends on the fellowship, the way it's structured.
That's right. It depends on the fellowship and it depends on the person's training. So I would look at, if you're looking in the US, you can first differentiate between ACGME accredited fellowships and non-accredited fellowships. If you're looking at ACGME accredited fellowships, you have to have completed an ACGME accredited residency, anesthesiology residency, in order to qualify for that. So I get a lot of emails from folks who seem like amazing and super interested. Unfortunately, that they just don't meet that criteria. There's nothing I can do. There's nothing I can do about that. But there are other programs in the U.S. that are not ACGME accredited that may be able to accept candidates who haven't done sort of the corresponding ACGME residency. If you do have done the ACGME residency and are interested in ACGME fellowships, another thing to look at is programs who can accept folks who have J1 visa status or H1B visa status. At Stanford, we accept both. A lot of programs, I believe, accept one or both. And so, but it is, unfortunately, it's a little, we've actually talked about this as part of RAFTA. We've talked about this. How can we get this information like more publicly available to applicants, because there are so many interested candidates from around the world. But sometimes it does involve a bit of like emailing individual programs to ask, like, do I qualify for this program?
And all of those programs, accredited or not accredited, are listed on the ASR website.
Yeah.
Stuart, Ryan, thanks a lot.
Yeah, thank you. And it might be something, a little worldwide playbook from RAFTA might be a really interesting tool that you guys could create so that people can access. Say, hey, here's how you do it. Here's the steps, and state by state, this works and this doesn't work. So anyway, thank you guys. You guys did a phenomenal job. I was really interesting conversation. There's more questions in the comments if you guys want to peek in there afterwards and answer them. But thank you and have a great day.
Bye, guys.
Thank you.
Bye. Well, then another great talk by a fantastic bunch. Yeah. I just want to tease a couple of things you mentioned before we get to our next speakers. So you mentioned the guidelines on the website. ASRA just came out with a brand new guideline on infection control for regional anesthesia and pain medicine procedures. So I'm going to throw this up here real quick. So if you go to the ASRA.com website on guidelines, this just came out brand new just a couple of days ago. It was published, the Consensus Practice Infection Control Guidelines, and it's in the Regional Anesthesia and Pain Medicine Journal, and free to access for anybody on that journal's website. So I highly encourage everybody to go there and check it out. There is upcoming, I don't know what day, but it's going to be very soon, the newest 5th edition of the anticoagulation guidelines for regional anesthesia and pain medicine. So that's going to be published very soon.
Hear about it at the spring meeting.
Yeah, there's going to be a lot of conversation about it at the spring meeting. There are some significant changes. As you guys know, I work on the app that goes along with the guidelines. I've been going through the guidelines with a fine-tooth comb, updating, and we've actually got a whole new app coming. It looks similar, but there's some significant changes in it. So your existing app, that won't update. We're going to have you go out and get a new version of this app because we've changed the code base behind it. So keep your ears out. We're going to try to get it published in the next couple of weeks as well so that it aligns with the new guidelines. So check out your app stores, iOS and Google Android stores, for the new ASRA Coags app. We'll be sending out emails and social media and stuff when that's ready to go. All right, we're up for our next session. We've got our group from HSS. Let's throw them up on the screen. Hey, Steve. Hey, Marissa.
Good morning.
Hey, good morning.
Good morning.
Good afternoon. No,
good afternoon for you guys. Yes,
yeah.
We've crossed the line.
Yeah, still morning for those out west.
Well, thank you so much for joining us. And I know the topic that you guys are going to be presenting is a hot topic for pretty much every day now in my practice. I don't know about you guys, but I'm running into it every day. It's these GLP-1s, and what do we do about them? And the rules keep changing. So I'm going to tease that beginning of the conversation. I'm going to remind people that are listening, if you want to, in the comments, throw your questions in. If it's appropriate for these guys to answer in real time, I'll throw it up for them. Otherwise, also tell us where you're coming from and watching, because I think some people have answered, but I know not everybody has shared where they're coming from. So we'd love to see where you guys are listening from. All right, we're going to throw you guys up on the screen by yourselves and let you get started.
Okay. Perfect. Well, thank you so much again, Raj and Stu, for the invitation. And if you could add Ollie Panzer also, he should be hiding behind backstage. There we go. So we're coming in from New York, Hospital for Special Surgery and Weill Cornell. Marissa Weber, presenting New York Presbyterian Hospital. I'm Stephen Haskins. I am a regional anesthesiologist. I trained at HSS, finished my fellowship back in 2013, became a POCUS enthusiast. I've been called an evangelist by some, although I don't know if that was necessarily a positive statement when it was said that way, but I'm definitely someone who's incredibly passionate about the role of point-of-care ultrasound, and excited to have an opportunity to talk to you all about a topic that is incredibly relevant. You're speaking about guidelines. In a few months, hopefully, knock on wood, if we get through these revisions, we will be publishing some clinical practice guidelines for gastric POCUS through ASRA as well. So be on the lookout for that. But today's topic is an opportunity to look at GLP-1 receptor agonists, just an overview of what they are, how they impact our practice, reminder, refresher of gastric ultrasound and its role, and then also a highlight of some of these guidelines and recommendations that have come out recently and the evolution that they've had on our practice. And I'm going to go over a little survey. But I want to introduce our panelists. Dr. Marissa Weber will be going first. She's an assistant professor of anesthesiology at Weill Cornell Medicine, New York Presbyterian. She completed her anesthesia residency at Thomas Jefferson Hospital back in 2020, and then went on to do a fellowship in regional anesthesia and acute pain medicine at Columbia. There she really sort of developed her POCUS skills and expertise. She's the POCUS course director for education for the fellows at Weill Cornell, and her academic interests have really been around GLP-1 receptor agonists and gastric point-of-care ultrasound. We also have Dr. Ali Panzer. He's an associate professor of anesthesiology at HSS, completed his residency at St. Luke's Roosevelt back in 2005, did his fellowship in critical care at Columbia in 2006, and stayed on there, became a true international POCUS expert, also serves as their director of perioperative ultrasonography until we were fortunate enough to poach him and steal him away over to HSS back in 22. And he's continued to be a leader in education and is currently the principal investigator of a multi-center trial looking at the role of gastric POCUS in assessing gastric contents in patients who are on these types of medications. So I'm going to hand it over to Marissa. She's going to share her slides and we'll jump into this.
And everyone can see my slides right now? Okay. Nope. Do you see them yet?
Yeah, we see
now
them.
we do.
Okay, perfect. Thank you so much. So good afternoon, everyone. Thank you so much for being here. So today I'm just going to talk about the GLP-1 receptor agonist. What do we really know, and what do we have yet to learn? So what is GLP-1? I know these medications have become incredibly popular, but I always like to kind of talk about what GLP-1 actually is and how it works in the body normally, and kind of what these medications have changed. So GLP-1, it's a gut-derived incretin hormone. It's produced by the body naturally, and it has a variety of sites within the body. And again, it's produced by the body after we eat. And usually within 60 to 90 seconds, it's quickly cleaved by dipeptidyl peptidase 4, or DPP4, to its inactive form. And once it's inactive, all of these effects that we kind of see, decreasing appetite, increased satiety, decreased gastric emptying, and decreased GI motility, disappear. However, the GLP-1 receptor agonists they mimic the action of GLP-1, but unlike naturally occurring GLP-1, they are not quickly degraded to an inactive form. They are designed to be resistant to degradation, and they have significantly longer half-lives with significantly longer mechanisms of action, which was when we started seeing kind of these adverse events related to their use. One thing I like to point out when we talk about the GLP-1s is that these medications, yes, they've been on the market for a long time, but these medications are not the same. Technically, exenatide or Byetta is a GLP-1. It was the earliest version that came to market in 2005. But as you can see, it was a twice-daily injection. It had a very short half-life, and it was not very efficacious. Over time, the medications developed longer half-lives, and they became more potent. So there's two issues when we talk about the GLP-1s, their half-lives and their potency. And there's really two medications that have consistently demonstrated the highest level of potency, meaning their ability to create weight loss. And those medications are semaglutide, Ozempic, and Wegovy, and tirzepatide, Mounjaro, and Zepbound. Once these medications really became popular in the last couple of years, once they came to market and they began having increased uptake in use and prescriptions by our endocrinology and our primary care colleagues, there started to be an increased observation of adverse events. So first off, there's a lot of case reports that were published, but this was actually the first study that was published looking at the presence of residual gastric content in GLP-1 users. So this study came out early in 2023, and it was just very, very popular because we were all, I think there was a lot of recognition that there was a potential issue, but there was no data kind of to help guide best practices. So this was a study. They looked, the cohort they looked at was 404 patients undergoing endoscopy who were taking semaglutide, 33 semaglutide users, 371 non-semaglutide users. And I think the thing that was really interesting about this study is the primary indication for semaglutide use, in this group at least, was weight loss. So about 90% of patients were taking these medications for weight loss, which there's always a conversation when we talk about these medications is, are any of these effects, or any of these the gastroparesis that we see in patients, is this just because they have diabetes? Well, at least in this patient population, most of the patients didn't have diabetes. And about 20% of the patients were obese, defined by a BMI of over 30. And they did find that perioperative semaglutide use was associated with a prevalence ratio for increased residual gastric content of 5. And these were patients who were appropriately fasted. You can see the average fasting intervals were 9 hours for clear fluids and 14 hours for solids. And yet they were still coming in and they still had food in their stomach despite following fasting guidance. The other thing that this study was very helpful for is it did look at the presence of digestive symptoms and the increased the increased risk for having residual gastric content present. So the reason this is significant is when we talk later about ASA guidance and symptoms driving ASA guidance, that this is actually where some of that original suggestions came from, this particular study. So it was a smaller study, and since then, for a few further studies have been published. A lot of these studies, I will point out, are looking at the presence of residual gastric content, and endoscopy and our gastroenterology colleagues are doing a lot of these studies because it does facilitate looking at the presence of food in the stomach. As anesthesiologists, we do always have the ability in our patients who are intubated to decompress the stomach, but nothing is really, especially when we talk about solid food, really direct visualization under endoscopy is really one of the best ways to, in terms of these studies of looking at the presence of food. So this was a large study. They looked at, it was a meta-analysis of 23 observational studies, including 262,000 patients. So a much larger study. And they looked to see the presence of residual gastric content, the risk of aspiration. And then they also compared patients who had just an endoscopy alone versus endoscopy with colonoscopy. So what did they find? They found that GLP-1 users had a statistically significant increase in the risk of residual gastric content with an odds ratio of 4.5. They did, so like the previous study, so they did kind of confirm that. They did find there was no significant difference in the risk of aspiration pneumonia. And one thing that I think was very important and they noticed was that there was a significant reduction in the presence of residual gastric content when endoscopy was done with colonoscopy versus just endoscopy alone. Well, why is that significant? As if you get to the pleasure to work in GI, you'll know that patients who undergo colonoscopy have to do a bowel prep, and they also have to do, at least at our institution, a prolonged liquid fast prior to procedure. So the prolonged liquid fast, there's a question of, does this reduce the risk of there potentially being solid food in the stomach when patients undergo endoscopy? And it seems like this study does suggest that there is that benefit. As we know, aspiration is a very rare phenomenon, and we talk about looking at rare phenomenons. Often we need to do large studies. So this was a population-based retrospective cohort study done is a database study using the TriNetX database. They looked at almost 1 million patients who underwent endoscopy, and they found 95% were GLP-1 non-users and 5% were users. And they defined GLP-1 users as patients who had been on the medications for 6 months and had received 2 refills within 6 months before the procedure. I think one thing to point out about a lot of these studies, because there are a couple of studies, database studies looking at aspiration in this patient population, it's very challenging because there's no way of really determining with these database studies whether patients are truly taking these medications, their doses. So I think that is something I always do caution when we're interpreting these studies. But what they did find was after propensity score matching for potential confounders, GLP-1 use did have a higher incidence of aspiration risk, 0.83% versus 0.63% in the non-user group. And they did note an elevated risk of aspiration pneumonia was observed in patients with propofol-assisted endoscopy, but not in the group where propofol was not used. So based on this information, and I think based on case reports and based on, I think, general concern for the population, there was an FDA update that was provided relatively recently, and they did put a warning label on all GLP-1s that there is a risk of pulmonary aspiration in patients on GLP-1s undergoing either a general anesthetic or a deep sedation. So I think that was not necessarily unexpected, but was of course a pretty impressive warning. So where do we go from here? The GLP-1s we know are associated with an increased risk of residual gastric food content in patients even who have followed standard fasting protocols. I think that has been firmly established. There is mixed evidence whether the GLP-1s increase the risk of aspiration. The FDA has put this label on all GLP-1s, and I think that further research, as I'll note, is needed. Pulmonary aspiration has a very high morbidity and mortality, and it can be a devastating outcome for our patients. We know that all patients with residual food content will always have the potential to aspirate under anesthesia. Unfortunately, we don't know which patients will and which patients will not. And I think ultimately randomized control trials are needed to fully elucidate this relationship going forward. And these are my references. Thank you so much.
Thank you so much, Marissa. I'm sure there'll be plenty of questions related to those studies that you shared, but I want to make sure that we have time to touch on gastric ultrasound and some of the recommendations and guidelines that are out there. So I'm going to hand it over to Dr. Panzer. Ali. And you're still muted, Ali.
Trying to manage here, and I think I shared my screen. Do you see my screen? Do you see it now?
So we see your desktop, but I would share the presentation itself.
Yeah, we're getting a little bit of the repetitive thing. So if you go to stop your screen share and then go to present, and then when you present, choose the window for your presentation, not the whole screen.
So share screen, and then
it should say window.
I don't get window. I only get share screen, like a blue button.
Let me see here. Try that again.
Oh wait, select window on screen.
Yeah.
I don't get that. I don't get that option. I can't click it.
Okay. Can you just share your screen and then minimize your StreamYard presentation after you share the screen?
Okay. Let's see. Share this window. Wait. How about now?
It was there for a second, then it went away.
Okay, repeating this. Now it's better? Not really, right?
No, I don't see it yet.
Okay.
We had it there for a second. Oh, wait, here it comes.
Try this again.
I've got this one. Is that it?
No, that's mine.
That's yours. Okay.
Share screen, allow.
Why don't we do this? Hey, Steve, do you want to do this out of order and let you present? And then while Ali's trying to get his share screen, I can kind of watch what's... Oh, wait, here it comes. I got it.
You got it? Okay. And now I click on present. You got it?
Oh, I think it went away.
Oh, gosh.
So close.
I don't know.
All right, let's do...
I hit play slideshow, it won't do it. Okay.
So a couple of options. Either we can let Steve go while you're trying to get the thing to go, or does anybody else have your slides? You could email them to me and I could share them.
Yep, I can do that. Let me just
Yeah.
do what I'm doing right now. Share entire screen.
Okay.
Wait. Oh.
And then
Is
let me
this
see your
repetitive? This
presentation.
is this repetitive thing, huh?
Yeah. So it's getting into a loop. So why don't we do this? Let's present Steve's, and then I'll put his on. And Ollie, do you have my? I'll put in the chat my email address, and then you can
Okay.
just email it to me.
Send it to you.
Yeah.
It's Keynote. Can you
Yeah.
use Keynote? All right, perfect.
Yep.
Love.
Yeah.
Thank you.
All right. All right. Well, this is a little out of order. I think it was going to be helpful to hear Ollie's summary of some of the recommendations that are out there, but I'll do my best to encapsulate some of that, and then we'll be able to delve into it. But I think it was nice. We had a great question from Jerry Jones. What are we doing? What are institutional policies and practices regarding these medications? And that's exactly what I asked a cohort of people around the U.S. and internationally as well. What are your institutional practices when it comes to GLP-1 receptor agonists? So these are the results of a survey that we sent out to the regional anesthesia program directors. I want to thank Mary Hargett for pushing this out. And we were fortunate to have 24 responses from 21 unique locations around the U.S. and a couple international responses as well. Canada and Greece. Thank you, Lenny, for responding. And so what are people doing around the country? Let's take a look. So these are different types of practices that we have. About 80% academic. We saw some private, some hybrid, and also military academic. And then, I think an interesting question, do you have a formal policy? And you can see that the vast majority of institutions at this point have instituted a formal policy regarding these medications. So this is something where, we're certainly setting things in place so that way ultimately these patients are found pre-op and there are recommendations given in the preoperative setting to minimize aspiration risk on the day of. So which guidelines do you follow? And this is where Ollie will be able to fill in some of the blanks. But back in June of 23, the ASA put out recommendations regarding holding these medications. And essentially what they said was, if you're on one of these medications that's a weekly injection, then you should hold it for a week. So that way it kind of helps, minimize the impact. These long half-lives that Dr. Weber mentioned during her presentation really are the source of a lot of these delays in gastric emptying. So hold it for a week if it's a weekly injection. If it's a daily injection, just hold it for a day. Recently in December, there were these multi-society guidelines that were pushed out by, let's be honest, some of our surgical colleagues who said, it's no big deal, just continue these medications as they are. And ultimately, the key takeaway is do like a colonoscopy type fasting. And if they have high risk, then you can adjust and use gastric ultrasound, which was a very nice thing that has been brought up in both of these recommendations and is definitely an evolution in terms of our practice. And then institutional specific guidelines. So most people are following, as you can see, 2/3 the ASA recommendations. Some have switched over to the multi-society guidelines, and other ones have these specific ones. Essentially follow the ASA if it's on for diabetes, if it's for obesity, which is often higher doses, and there's escalation of those dosing, hold it for a month. Clears for 24 hours, and don't change your dosing unless you have evidence of severe gastroparesis, and assess on the day of. And combined, high-risk patients you hold and follow a liquid diet. And some people, you're doing an RSI, and anyone who has nausea pre-op. So it's sort of interesting to sort of see what's out there. I want to ask how many people have committed to this 24-ish hour of liquid diet, and it seems that most 62% most do not require this prolonged fasting that has been recommended for the multis, especially guidelines, and instead 2/3 are still kind of following the recommendation of holding the medication, while 37% now are recommending this prolonged fasting and liquid diet 24 hours before surgery. Some have variations, hold solids for 16 hours, hold liquids for 8 hours. So it's interesting to see sort of, what drives different institutional policies. But when it comes to gastric POCUS, how many people are using it to guide management? So no one's using it always. And the vast majority of people are using it sometimes. And so I think that's probably similar to our practice. Sometimes we use it, sometimes we don't. If they follow the recommendations to the T, then we don't need to scan them. But when there's variation in terms of their fasting or how they've held the medication, that's where we will do a gastric ultrasound to guide management. How long have you been, following these policies? So again, most 58% for 6 months to a year. So really, this is a scenario where we have heard about these drugs and are implementing these policies, but still that's a little over 50%. There's still quite a few people who are sort of, this is a recent development in terms of their institutional practice. I thought this would be an interesting question. I got the answer I expected, which is, are there any differences between, your fasting guidelines for someone who's going to get a regional anesthetic versus a general anesthetic? And no, everyone, we all follow the same guidelines. But, sometimes people say, well, I'm just going to do a spinal light sedation, so it's no big deal. But it seems that across the board, everyone would postpone or cancel if they're outside of their institutional policies. And this is a question, are people thinking to update their guidelines, and essentially, about a third are, and a lot of people are not really sure, and some people are going to stick with what they have. Additional comments, I think, the key is there's a variety of practice out there, and depending on, the impact that the surgeons have in terms of your guidance of your institutional policies, I think, ultimately, people may be moving into this direction of not holding the medications and continuing them. And gastric ultrasound, I think, is going to continue to be a really important tool as we evolve in this process. And want to thank our speakers. Want to thank Stavros for connecting us with Dr. Mocha and Block and the rest of the Ezra team to be a part of this process. Thank Mary Hargett for helping push out that survey and her support in this, and of course the Ezra team, Raj, Stu, Ed, and yeah, we have, because of our technical difficulties, have bumped up against our time a little bit. But I do want to give Ali a moment, maybe to just touch on the guidelines. Maybe don't review gastric ultrasound, just because there was a big POCUS session this morning that already went into it, and maybe you can just kind of touch on the two guidelines to give some additional insight into that.
Take your time, Ollie. We'll find some time.
Yeah. And can you unmute your mic, Ali? And just let me know.
Yep.
I've got your slides, and I'll advance.
Yeah, perfect.
Just tell me when to go.
All right, perfect. Yeah, thank you very much. So should I review some of the gastric ultrasound is suggested, or should we just go to the guidelines?
If you want to give a couple highlights, that'd be great.
Okay, so in gastric ultrasound, I just listed that because, as Stephen mentioned, we are doing a multi-center study, and in that we kind of did a lot of gastric ultrasound, and I came across a couple hurdles, which explains, I think, from, if you look at some of the ultrasound guided studies that looked at residual gastric content, there's quite a variability. Like one study even reported up to 50% residual gastric content with normal fasting guidelines. And whereas other studies are more like in the 30% or 20% range. And so, Raj, if you could advance a few slides. So, first of all, the way we look at ultrasound is is at the gastric antrum, and that was defined to kind of give a good introduction or like guideline how to scan. That we use the aorta as a guideline or as a guiding anatomical structure. Advance. And, the reason for that is, and the reason for why we do it in two positions, supine and lateral, is that if I scan in the supine positions, I might miss small amounts of fluid. And if you advance, turn the patient lateral, the antrum starts becoming, acting like a funnel and kind of gathers whatever fluid is collected. And therefore, the right lateral decubitus position is really important to make a final judgment on what's in the stomach and what's not advanced. And so this is what happens in real time. So this is supine on the left and then advance. You can see what a difference it makes if you turn a patient lateral. So the entire content just accumulates in the antrum. Advance. And so this is the regular sonar anatomy. I'm not going to lose too much time here. The aorta is the key structure to be at the right level. And then you see the antrum here, advance, is a small round structure with a thick black ring on the outside. That's the muscle layer, the muscularis. White ring inside, that's the mucosa, and then a little bit of fluid inside, which is normal. I highlight here that the muscularis is nice and big, and it's easily visualized. Advance. Clear fluids we've seen. I think there's not much to say. Important again that you're at the level of the aorta. The reason why the aorta is so important, even if you scan over to the IVC, I've learned doing the study, is sometimes you scan over and you start to look at the duodenum. And interestingly enough, this is just my observation, but interestingly enough, most of the time, even if the stomach was empty, the duodenum seems to contain clear liquid. So many times, if you overscan, meaning you're using the IVC instead of the aorta, you might mistakenly think there's fluid in the stomach, even though it's probably going to be small. Advance. So the evaluation of clear liquid is by measuring the CSA. I think everybody knows how to do that, and I'll show a table that Perlas published afterwards, advanced. And I think this one is what I really would like to talk about. I think that's the crux a little bit of gastric ultrasound at this stage. It's the solid early stage, which we describe basically, if you see on the left, by looking at an layer of air underneath the gastric mucosa that's supposedly pretty bright. The aorta sometimes is difficult to see because a lot of it is going to be darkened out by the shadow from the air layer in the stomach. Advance. But I want to highlight that, advance one more time, that if you have a layer that's broad, like the orange line that I said, more like in the shape of a banana, you can have what you see on the right side. This is during the study, and we were all kind of like, is this full or is this empty? And, most of amongst the expert, we decided that this is actually empty. And the reason for that is, even though it has a little bit of an air shadow, advance, you can see that the shape of the stomach is a little different. It has more not a banana shape. It has more like a C shape, or like a crab with its claws. And that means that the antrum is pretty small. Also, you've seen that the muscularis layer is very thick. And the muscularis layer typically becomes thick if the stomach is empty, whereas if it's full, it's stretched out. And you don't see that anymore, but on the left side, you can see the muscularis is barely visible. Advance. So many times what we started doing, if we're not sure, we actually traced, like we're do that for liquids. We trace the antrum and to see if it correlates with a small CSA area. Obviously, to some extent, this is guessed, but it proved to be a good guidance for us. Advance. Advance. And then this is another image for a clear, like broad base of a air shadow. That's a full stomach, okay, on one of our study patients. Advance. This is the solid stage. This is like a hypoechoic material in the antrum at the level of the aorta. You can see that here by the area that's marked with an A. Advance. So, this is the quick evaluation. I think most of us might have heard of it or might be somewhat familiar with it. This is from Anahi Perlas. 2 grades, 3 grades, grade 0, grade 1, and grade 0 and grade 1 are considered low risk for aspiration. Grade 2, which is based on fluid, clear liquid fluid with a high area, that is considered full. Advance. And this is a nomogram for the measurement of the CSA that allows you to kind of, if you're within the green area, it's this differentiate by age to quickly see if this is considered more than 1.5 ml, which is available on the gastricultrasound.org website. Advance. Okay, so this is the last 2 minutes. I want to talk about the new guidelines. This is from the published in Anesthesiology by Dr. Oprea, and then Advance. There's the multi-society clinical practice guidance. And I'll talk about both different, they have both slightly different approaches, but I tend to kind of like the anesthesiology publication a little bit more because it's more concrete. Advance. So the multi-society guidance, the big theme here is shared decision-making with patient, surgery, anesthesia, and prescriber. And they have several recommendations. Recommendation 1, Advance. Is, the high-risk factors are considered escalation phase, Advance. Higher dosing for obesity, typically, if it's taken further, Advance. Weekly dosing is considered higher, even though the studies don't seem to 100% support this, I think, for Advance, sorry. GI symptoms present in the pre-op clinic or on the day of surgery, and Advance. Or comorbidities that are known to cause delayed gastric emptying, like gastric dysmotility, Parkinson's disease, chronic kidney disease, diabetes, etc. Advance. And so their recommendations actually for low-risk patients, meaning they don't have one or less of these risk factors, to continue the GLP-1 Advance, and then Advance again. The high-risk patients, they recommend, and it's pretty vague, to have basically a discussion of risks and benefit involving all the involved specialties, surgery, anesthesia, prescriber, and patient. And then they have a second set of recommendations how to decrease aspiration risk in general, and they recommend Advance, a 24-hour liquid diet, but they stop short of saying when to hold that. They all Advance. They think if there's any doubt in clinically at the day of surgery, that gastric ultrasound can be used to help. And that Advance, if there is doubt about empty stomach, that you need to have a discussion about proceeding, how to proceed or to delay, and consider RSI. Advance. So the ASA guidance is a little more specific. And I like that because of the study that Marissa mentioned earlier, the endoscopy study that showed that patients who have symptoms on the day of surgery actually have a almost similar elevated risk for having a full stomach despite adhering to the gastric, to the fasting guidelines. So that's what they base their recommendations on. So in the perioperative period, if you're tolerating GLP-1s well, that means you don't have symptoms, abdominal symptoms of any sort. Advance. They recommend that you hold solids and non-clear liquids for 24 hours, high carbonate clear liquids for 8 hours, and clear liquids, purely clear liquids for 4 hours, because the 2-hour mark that's recommended right now has not led consistently in GLP-1 patients to empty stomachs. And this is based on different modalities, scintigraphy or ultrasound. Advance. If you are poorly tolerating, they mean you have symptoms. you should either have, a discussion and sort of discuss postponing, or if it's time sensitive, which quite many times that will be the case, they said they increased the clear liquids holding to 12 hours. But the switch from solids to clear liquids as well as 24 hours. And then consider modifying your diet and consider holding doses if no responses, but they clearly say that that's their least desirable intervention. Advance. And so of the day of surgery, again, the symptoms, GI symptoms are in the forefront of the decision model. And so if somebody's asymptomatic and has appropriately fasted, 24 hours for solids, 4 hours for clear liquids, you proceed. If you have symptoms of any sort, gastric discomfort, light nausea, diarrhea, any of it, you basically have to decide as a clinician how you want to proceed. They definitely do recommend gastric ultrasound to help in that decision model. But in the end, and that's where they pick up what the multi-society guidelines is, you need to have a discussion and a clinical decision making. And I think I went a little over, I apologize, but I'm done here.
All right, we're back here. Well, thank you guys. Sorry for the technical issues, but I'm glad we got that sorted out. This is an important topic, and I think that everybody is interested in dealing with this in their own institutions. Thank you so much for attending and being part of this. We really appreciate it. And we're going to get our next team up here right now. Thank you, guys. Have a great day.
Thank you. Really appreciate the opportunity.
All right. Here we go. Max, Amanda, Kaylin, how are you guys?
Great. Thanks for having us.
We have our UT Texas representation here. Max, you want to do quick introductions of everybody?
Sure. I'll go first. Max Ekman, professor and chair at UTSA Anesthesiology. I'm also on the board for ASRA. So it's a great honor and pleasure to meet friends across the world today. And I'm joined by two of our regional anesthesia specialists. I'll let them introduce themselves today, and I'm very thankful for their time and involvement.
Amanda, you want to go?
Sure. Amanda Shackle at UT San Antonio, an assistant professor here, involved in the acute pain service and regional anesthesia, and I am also our point of care ultrasound director.
And Kaylin.
And I'm Kaylin Sachs. Did my regional fellowship up with Raj at Vanderbilt, and then back home here in Texas. So happy to be here.
Yeah, this is great. It's like family here. So, Max and I went to residency together, and Amanda and Kaylin are at Vanderbilt, and so we're all kind of in one big happy group here. So I'm gonna put your slides up, and we'll take me and Stuart off.
All right, so we'll go ahead and jump in. So, we're talking about regional anesthesia for proximal AV access, and why this is important is that you can see from this graph since 1980, the incidence of end-stage renal disease in the United States has increased exponentially. And while the numbers of transplants have increased too, they just haven't kept pace. So most of these patients are dependent upon hemodialysis. And if you look at this graph based on the regions, you can see that it varies by region. You see our star there down in South Texas, deep in the middle of the densest prevalence of end-stage renal disease here in the United States. So our first question is always, where will the AV access be? And our surgical colleagues try to start distal, but oftentimes because of vascular disease or vessels that aren't big enough, they end up having to move more proximal, or as complications arise, the fistula must be moved more proximal. And why is that a problem? Is that all of our favorite brachial plexus blocks spare the skin of the medial upper arm, since it's coming from the intercostal brachial nerve, which is not part of our brachial plexus. So we'll turn it over to Max to talk a little bit about the anatomy.
Thanks, Kaylin. Yeah, so it's a conundrum, getting good coverage of the upper extremity and how we get some of that proximal medial part of the arm, and also perhaps deep into the axilla if the procedure is even getting up that far. And so, as many of you are aware, the intercostal brachial nerve is important for that. And recent anatomic research has identified that certainly the T2 spinal nerve root is consistently, almost all the time, responsible for sending that innervation down to the chest wall and the arm. And its course is variable, but essentially comes from the spinal root and eventually enters a fascial plane that is superficial to the latissimus dorsi and the conjoint tendon between the latissimus and teres major. And so that's an area where it's potentially accessible, where it's emerging from the thorax and where it's going down the arm. And it gives us an opportunity to block it in one of those two locations. So today what we'll talk about is what are some different strategies for blocking this nerve using ultrasound guidance versus the traditional landmark technique, which many of us learned in training. I did it, and what I would do is just feel for the coracobrachialis muscle and then do some kind of subcutaneous skin wheel, both anterior and posterior on the arm. However, what I found, and many of you have probably found, is that the coverage is not very reliable. And so I'll talk a little bit about doing the distal intercostal brachial nerve block, meaning distal to the axilla, and essentially looking at the key landmarks for that. So we'll dive into the video here. So what you're looking at is a very proximal view of the axillary artery and plexus. This would be right up in the crack of your armpit. And sorry, we're going to go back into that. And so what you're looking at there is you see your artery and you see your musculocutaneous nerve and then all the nerves around the artery. And then what you're doing is you're scanning inferiorly, so down the inner side of your arm, and looking at the fascial plane that's lying over this big muscle group. This big muscle that you're seeing is the latissimus dorsi and its conjoint tendon with the teres major. So these are now labeled. You can see that. And you can sometimes with ultrasound see a little hypoechoic nerve, maybe a hyperechoic structure and a fattening within the fascia. But it's been confirmed on anatomic study by several investigators that this plane is the conduit for those nerves. And so whether you see the nerves or not, if you can field block in this fascial plane, it's been demonstrated that your likelihood of numbing at least the medial upper arm distal to the axilla is extremely high, almost 100%. Now, what it's not going to get, as my colleagues will get into, it's not going to get your axilla itself or anything on the chest wall. And so we'll talk about that. But this is the view, and you look for this muscle signature, and you see that the fascial plane is contiguous with the axillary artery. So we'll turn it over to one of my colleagues to talk about the proximal block.
Thanks, Max. Now we're going to look at the proximal approach here. And here what we have is the infraclav view. And then as we scan medially and kind of tilt the probe to look into the chest, what we'll have is the second rib. And so kind of as we looked at the anatomy, we know that that nerve is kind of coming off of, the intercostal branch from that second rib. Sometimes it's the third rib, but when we kind of zoom in here on this image, we've kind of scanned more medially and now are kind of shallowing out our image here to show the pectoralis major, pectoralis minor, and then of course the second rib. And the goal with this approach would be to deposit the local on top of the second rib here and to open up that plane there to allow local to kind of spread and target that nerve at this proximal location. The nerve is branching at the midclavicular line. So by kind of scanning more medial, you'll be able to target that nerve before it exits the chest. So now when we kind of look at the evidence, like we kind of alluded to earlier, the traditional landmark technique that, we all learned, and we all may use, for like tourniquet discomfort, isn't really the most efficacious way of getting these nerves. When they compared, doing the landmark technique versus doing an ultrasound guided approach, there was obviously greater efficacy in targeting these nerves when ultrasound guidance was used. And then when we look at doing a proximal approach versus a distal approach, both when combined with the supraclavicular block are effective for AV access surgery, with success rates, reported in this study around 93, 94%. But as, as alluded to earlier, doing the more distal approach does spare the axilla 25% of the time. And so performing the proximal approach can get more consistent coverage of the axilla and of the chest, some of the chest wall as well.
All right. Thank you, Amanda and Kaylin. So with that, little brief time for discussion. We had to develop our expertise in these techniques locally and clinically just because of the need, as we do almost on a daily basis these procedures. And so we're curious to know, what others do at their institutions to manage this problem. And if you are, how much are you using regional, for example, versus general? And within the regional group, are you doing any of these advanced ICBN techniques or still doing field blocks? And so interested to hear the commentary. I see a question. The PEX block is described over the fourth rib between the major and the serratus anterior. Will that still block the ICBN? So I'll weigh in on what I think. I think it could theoretically do that. The ICBN, the concentration of that innervation is from the second intercostal space, and some from T1 and T3 also, but for sure, almost 100% of the time, it's the second rib. So I think a slight modification approach would be a little bit more likely to be effective, but I'm not sure if that's valid or not. That's my opinion.
I want to echo that and just highlight that if that plane is open, local is going to spread, levels above and below. And so it is possible. However, when we routinely use this block for our AV access surgeries, we do try to target higher rib space, obviously the second rib ideally. But even, sometimes occasionally I will target the third rib, knowing that there's some spread that's going to occur in that plane if you open that correct plane.
Yeah, I think that, they refer to the PEX block in the previous comment, and I think that nomenclature is a big topic these days, and so we should talk about specifically what that means. So in my mind, a pectoserratus block, as you guys showed in your diagram, what was formerly called the second part of the PEX2 injection, may spill over to get the ICBN depending on how lateral you go, how posterior you go, and how high up you are the axilla. So just my 2 cents on that. There was a question on here about supraclavicular plus distal infiltration, if any sparing occurs, local infiltration by the surgeon.
Yeah, I think certainly that, in our experience, that certainly can work. I think the better upfront coverage you can get, the better likelihood you make it through a long surgery without too much sedation and other problems like that. I will say when I do the distal, I like the distal ICBN ultrasound approach. I can basically combine that in one needle access point, going in, blocking the plexus, and if the needle is long enough, getting into that fascial plane all in one view. So it's actually pretty fast. So I don't have to add too much time. I don't do 2 needle pokes. I just do 1 poke and get everything.
And similarly, I'll sometimes do an infraclavicular and then pull back underneath the pec minor there in the plane right above. And then you can do same needle pass and get both of them at the same time.
And then Dan says, I've begun to add a serratus anterior block instead, but same reason. Use it for ulnar nerve transpositions as well. We've got one more comment here. Can the proximal ICBN be subjectively be effective with pain relief, even if an exam shows no change in sensation? Can fascial plane blocks produce analgesia without dermatomal detected changes?
I think so. I think the literature has shown that with various studies. We don't routinely check the dermatomal coverage, but when these blocks are performed, anecdotally, there's a pretty low failure rate. When these additional injections are added, especially the more proximal one, which is the one I routinely perform more often.
Another question here. Why not a T2 intercostal block? I'll bring Stuart back on here too. So why not a T2 intercostal block posteriorly?
Yeah, I think that's definitely an option. I think it's just a little bit more upfront with moving the patient to position changes, where all of these can just be performed with the patient in the same supine position. But I think that would work as well.
Yeah, we added it in ours, and we found we get better surgical conditions during it by adding in the plantar vertebral. Haven't compared it. We just compared the infiltration. We found that we get less interruptions during the surgery, just a bit of a denser block in the axilla when we added that to our brachial plexus block.
All right, and then we got another comment here. With the brachial plexus block, have you found surgeons were able to do an AVF distally when they didn't think they could because of the sympathectomy? So I'm guessing that means that they had better targets.
Yeah.
Right. There's actually some literature in the vascular surgery journals that talk about higher success rates with AV fistulas versus grafts because of the vasodilation that you get with the sympathectomy, and higher success rates of the grafts and fistulas under regional anesthesia, which is a whole nother topic that we didn't really talk on today.
Do you guys want to move on to the hip section real quick? I'm going to put there we go, back up here.
All right, so we're going to change directions and now talk about regional for hip fractures. And again, a little bit of background. The incidence of hip fractures in the US, you can see that in the early 2000s, we started to see a dramatic increase. And while projections show it leveling off around 2050, we know that our population is aging. So the gross numbers of hip fractures by 2050 are projected to be over 300,000 per year in the United States. And these are injuries that have high morbidity and mortality. We're talking about in 1 year mortality to between 20 and 25%, which is worse than most cancers. And it's also something that's highly expensive to our healthcare system, with some projections saying anywhere from $5 to $20 billion a year. And when I talk to some of my colleagues, they say, is a block even necessary for this patient with a hip fracture? Sometimes these patients aren't complaining of a lot of pain. But if we look at the REGAIN trial data, Newman and colleagues found that more than 70% of patients reported severe pain, greater than a 7 out of 10 after hip fracture surgery. And additionally, there's several national guidelines that recommend the routine use of peripheral nerve blocks instead of just systemic therapy, my favorite of them being the American Academy of Orthopedic Surgeons, in addition to some other large international groups as well. And then Newman and colleagues look to see how often blocks are being used for hip fractures in the United States compared to elective knee and hip replacements. And you see in the yellow that 50% of knee replacements are getting blocks, whereas in the light blue at the bottom, less than 5% of patients with hip fractures are getting blocks. And compared to our colleagues in Canada, about 20% of the time they're doing blocks, and over 50% of the time in the UK. So if we want to do a block, let's talk a little bit about the anatomy.
Thanks, Kaylin. So, the anatomy of the hip, neuroanatomy, can be kind of divided into the anterior portion and the posterior portion. And for simplicity, really the anterior is where most of your money is at, so to speak, while nociception is present on both portions of the capsule. Posteriorly, it's a little bit less clinically impactful, though I would not say it's not impactful at all. But if you're going to put some attention to regional, placing it in the anterior innervation gets you more bang for your buck, so to speak. And so that innervation comes from the femoral and obturator nerves, as you know, and the accessory obturator nerve. And that little red patch you're seeing is where most of the nociceptors usually preside. So that's why a lot of patients with hip problems or hip fractures have pain into the groin and thigh. And so if you look at the lamina, look at the anterior inferior iliac spine and the iliopubic eminence, which are the bones that sort of are very close to your acetabulum, that's a key landmark that we're going to show you as to where some of these fascial planes are relevant. And if you can imagine the iliacus and this iliopsoas muscle overlying all of this, that's another key feature. And so just to help you understand, generally speaking, when you look at joint innervation, at some point very proximally, the nerves are in some kind of intermuscular plane. And then as you get very distally, they dive beneath these muscles and become very close to the capsule. And so that's going to be very relevant to the ultrasonographic anatomy of two different plane block options that we'll present to you today. So with that, I'm going to hand it over to my colleagues.
So the first approach being the SIFI, or I hear some people call it the sci-fi, which is the superinguinal approach. So superinguinal fascia iliaca. So when we start to scan, we were sagittal there over the ASIS, and then we've now scanned medially and inferiorly to show the AIIS. And then we get that very classic bow tie picture that you saw there. And that's with the sartorius and the internal oblique muscle. The fascial plane that you're targeting, which is the fascia iliaca, lies just underneath that. And so what you'll do is come inferiorly towards the superiorly towards the, on the other side of the pelvic brim, and then deposit your local underneath that fascial plane there, just on the other kind of past the pinch point of that bow tie there. Sometimes it's helpful to note the deep circumflex iliac artery there, because that'll kind of help tease out exactly where that plane is, because it's sometimes hard to see. And what this does is, before we talk about the second approach, is we're blocking some of these nerves, like we alluded to earlier when we talked about the anatomy, before they exit underneath the inguinal ligament and begin branching. And so now we'll look at the second approach, which is the Pang block.
So talking about the Pang block, again, I like to start over the ASIS, nice, really superficial bony landmark in the transverse plane. And again, sliding inferior and a little medial, trying to find that brim of the pelvis there and looking for the bright white psoas tendon. So if you look here, we can see now the AIIS and swinging over to the iliopubic eminence with that bright white psoas tendon. And then more superficially, you'll see the femoral vessels and the femoral nerve, trying to stay away from those as you come down and touch the pelvic brim. So as opposed to the superinguinal fascia iliaca, where you're targeting more closer to the origin of these big nerves, we're now targeting those smaller distal nerves, and it's a more definitive endpoint. Come down and touch this bony landmark, as opposed to trying to find a fascial plane, which, to be honest, can sometimes be challenging to find. So we're looking at a little bit of the evidence, and this isn't necessarily new. The Cochrane Review back in 2020 released these statements with high degrees of certainty that blocks can reduce pain on movement within 30 minutes of block placement, which could be helpful if you're trying to position a patient for a spinal for the surgery. And it also is reducing the acute confusional state after blocks are performed. And this is another interesting study that looked at long-term survival after receiving peripheral nerve blocks. And this is retrospective data from a hip fracture registry in Australia and New Zealand. And they found that patients who got blocks both in the ER and the OR had a reduced 12-month mortality, as opposed to patients that got a block just in the ER or just in the OR did not see that same survival advantage. And there might be several reasons why this is happening, but it's something interesting to think about, that maybe we need to have protocols in place that are providing these blocks not only in the setting of surgery, but also when these patients present to the ER. And when we think about the fascia iliaca block, how does the superinguinal compare to the infrainguinal fascia iliaca? And this is a study that looked at healthy volunteers, and they each served as their own control. So on one side, they had the suprainguinal fascia iliaca block performed, on the other side, the infrainguinal fascia iliaca. And they found that the suprainguinal had more consistent block of the medial, anterior, and lateral thigh as compared to the infrainguinal. And then they looked on MRI and saw the spread of their local anesthetic and saw that more consistently, the suprainguinal fascia iliaca had spread of local anesthetic to the anatomic location of the femoral, lateral femoral cutaneous, and obturator nerves on MRI.
And then when we looked at, comparing like Peng block versus doing a fascia iliaca, there was this meta-analysis that came out a few years back where they looked at several randomized control trials here comparing Peng versus fascia iliaca. Although a few of the randomized control trials did not tease out whether or not it was a suprainguinal approach versus an infrainguinal. Many of these included both. And what they found was the Peng block resulted in significantly less opioid consumption compared with the fascia iliaca block. However, when they actually teased out and looked at the Peng block specifically against the suprainguinal approach, not just including the fascia iliaca plane in general, there really was no difference in pain scores. And they looked at several different endpoints, 6 hours, 12 hours, and 24 hours.
All right, so hopefully this stimulates some of your thinking and shows you that there's some options, both suprainguinal and close to the joint. So curious to know what everyone's thinking about how this affects their practice. What we're seeing in our region is a tremendous increase in longevity of patients. And so we're seeing, it's not uncommon for us to see 80 and 90-year-old patients who have a hip fracture, and trying to limit their exposure to systemic medication is, of course, an obvious benefit. And so we're curious to hear what are your techniques and solutions in your regions.
So I've added a question here for you guys. Can suprainguinal fascia iliaca block result in no motor weakness?
So I can talk a little bit about that. I think that is a concern, that if you are targeting, the more proximal origin of some of these nerves, like the femoral nerve, then you are at risk of having motor weakness. But oftentimes, because the suprainguinal approach is a volume-based fascial plane block, if you're using a more dilute local anesthetic, then that's going to be less likely. So I like to edge towards more of a dilute local anesthetic so I can give more volume and get better spread.
Yeah, and I've even used it in day case hips. I think the volume and concentration is really important. Low volume and lower concentration gives you analgesia and doesn't interfere with ambulation. Another question here: do you have a protocol for blocking hip fracture before arrival to the OR in the ED? Who does it, and what are the logistics?
That's a great question. We're in process of. We've met with several different, it was a multidisciplinary group and included some people from the ED, our nursing, our surgeons, and it's not live yet, but there is a plan to have APS involved in these patients early, such that a consult's triggered whenever the patient is in the ER. And then we even have some, so some help from, our ED colleagues on that. And so what will happen is the patients will get blocked early and then reblocked at the time of surgery.
Yeah, and that's something to watch out for. We had an electronic health record order set that triggered a lot of the appropriate investigations, called us, regional anesthesia team, also called the social work, because often these patient stays are delayed because of their home situation and the increase in care needs. So yeah, I think that multidisciplinary team approach and thinking just beyond you and the orthopedic surgeons, we had pharmacy involved, ED involved, and I say also the social work department as well, to try and get these folks not only have their fracture repaired, but also think about getting them home. So these are certainly ways that we can think, and improve. We have, so somebody here says, sci-fi and ER and paying in the operating department. I think that's an interesting one. We are doing one there and another in the other. I think we end up doing them both in both places. I think it probably all depends on the expert, the individual. Have you guys got one you're doing down the ED, or one you're doing more on the day of surgery right now?
I think personally, I end up doing the suprainguinal fascial iliac a little bit more frequently. Sometimes the views can be difficult depending upon body habitus. So I really think A block is better than no block. So if you are struggling to get a view for one of them, then I've had times even with some of our obese patients just doing the infrainguinal approach. But I think it's just whatever your skills are comfortable with and where you find the best view is where I tend to go.
I love this half hour. Thank you so much for giving your time. ASRA is all about volunteers, and thank you for giving up your Saturday. And we're going to move on in the interest of time. And thank you, Texas. And great to see you all and great talks. And
thank you so much, guys.
Thank
you.
Have a great day.
Thank you.
All right, Stuart, that was, God, I'm just blown away by all these presentations. I mean, we're just getting a lot of information in a very short period of time. It's great. We've got our team from UVA on deck, so we're going to bring them on. Yeah. Hey, Ashley. Hey, you guys are muted. Let's pull the microphone on. There's a little mute button at the bottom. Let me see if I can unmute you. Here, I got you. You're on.
Got it?
Yeah.
Yeah.
All right.
Hey, how are you guys?
We are great. We are excited to be here.
So you want to do introductions of who you've got there?
Yeah, so I am Ashley Schilling, and then I have, can you see us?
I can see two of you.
Okay, so Brittany Dealing, and then
there's the third one. There we go.
Matt Bames. Yeah, we're all here together live.
Awesome. Thank you. So you've, do you want to start with your slides, or do you want to, what order do you want to do things?
Yeah, I mean, I think we're ready to jump right in.
All right.
If it's good for everybody else.
Go for it. I'm going to pull it up. Here's your slides.
Right. We got a little.
And
are you ready for it?
There we go.
All right.
That's awesome.
Okay, right. So we're
gonna jump off the screen. We're gonna let you guys present.
Okay, great. Thanks, Raj. Thanks, Stu. Thanks, everybody. We are delighted to be here on World Day of Regional, and we are going to be talking about Swift Recovery, the Arthroplasty Eras Tour. We are in Virginia, Charlottesville, Virginia, at the University of Virginia, which is on the East Coast of the United States. And we're seeing people from across the world that have tuned in. So thanks for being here. So we get a quick 30 minutes to talk a lot about a lot of material. And we wanted to really focus on making outpatient joint arthroplasty work, both in the pre-op, the intra-op, and the post-operative eras. So all the way throughout. And we have a little Taylor Swift theme. We feel like there's nothing more unifying in the world than Taylor Swift and her music. So she's going to be making some appearances throughout our presentation. So everyone has seen this data. It wouldn't be a talk about total joints if we didn't talk about the increasing volume of joint arthroplasty. So from 2020 really onward, this was a study from 2023 looking at the increase and the volume of joint arthroplasty. Oh, sorry, this is Taylor Swift's net worth graph. Let me switch this. So this is the volume of total hip and total knee arthroplasty from when it was approved as outpatient surgery to 2060. So as you can see, it's exponential. So we are going to be doing incredibly high volumes of joint arthroplasty, and these are going to be moving to the outpatient setting. And so that is really our focus today, is to talk about outpatient joint arthroplasty specifically. And there's some things that make it pretty unique. There has to be patient buy-in. Without this, you will not be successful. There also has to be family buy-in. Patient selection is critical for having a strong preoperative clinic and good screening. There has to be competency in pre-op preparations and education. The facilities need to be adapted doing outpatient surgery, as do the surgeons. So we need surgeons who can work with minimal blood loss, good wound management, VTE prophylaxis. And I will say that tranexamic acid has really revolutionized outpatient joint arthroplasty. We all need, know the importance of skilled anesthesia teams, which is why we're all here learning about regional and acute pain. And we also need strong pain management techniques. There has to be robust patient and family education throughout the process, good social supports, and then good ways to communicate sort of throughout the perioperative process. So when we talk about making joint arthroplasty work for outpatients, the first thing we need to think about is what prevents them from going home, what makes them have to stay. And there have been a number of studies, including this systematic review that is on this slide, looking at what are the reasons patients don't go home same day. And it seems, based on all the studies that we have, that nausea, hypotension, pain, which is something that we know how to manage well, and failed PT and urinary retention are the main reasons that patients do not discharge same day. I just want to say this is truly Taylor Swift that fell off a treadmill on the bottom left corner, but these are the reasons patients don't successfully go home same day after joint replacement. So these are things we need to be thinking about. At least in the United States, not all of our patients are equal in their health, their comorbidity profile. So it's really important that we're looking at picking the right patients for outpatient joint arthroplasty. They all can't be superstar healthy. So this is something that's critical, and we'll talk about pre-op screening in a little bit. The other thing I wanted to mention is that not all facilities are equal. Some outpatient joints are performed in inpatient settings, some at hospital outpatient departments, and some are actually performed in freestanding ambulatory surgical centers. And so this is going to come into play with regards to what patients should have outpatient joint arthroplasty and where that should be done. We at the University of Virginia are really lucky to have an incredible orthopedic hospital that's actually freestanding. So it is separated from the main hospital. So that is something that we have to think about when we are looking at patient selection. But we're really lucky that we have the ability to keep patients overnight. So we staff our center with nurses overnight, so patients can stay if they need to. About 97% go home same day. We have the ability to check labs. Within our facility, we actually have 2 units of O negative blood available, as well as emergency equipment, ultrasounds, all the things we need for regional. We have a pharmacist on site during the day. We have surgeons that are in the building until nighttime. And then we have a physical therapist that's on site to help our patients until they are discharged home. So we appreciate that we have a lot of luxuries that not all institutions will have for performing outpatient joint arthroplasty. So patient screening, this is kind of where it begins. So we need to pick the right patients for outpatient joint arthroplasty. And unfortunately, there isn't strong consensus on this. There's thousands of studies now looking at this. A couple of the things that we look at that might deem a patient inappropriate are increasing age or frailty index. High SA scores is also something that's considered. Increased BMI, decreased albumin, which might be a sign of nutritional status, patients with bleeding disorders. Certainly patients with end organ diseases need to be evaluated really carefully for outpatient joint arthroplasty. And then social exclusions are also important. So I just wanted to present here quickly the outpatient arthroplasty risk assessment score, the ORA score, that was created by an internal medicine physician and an orthopedic surgeon in Indiana. And what they determined after seeing thousands of patients for joint arthroplasty was that there are certain comorbidities that increase their risk of failing same-day discharge. So there are 9 of these that are listed here. And that we can come up with a score, a low score being positive predictive value of patients going home same day, a higher score being patients less likely to discharge same day. And what we found using this score, it has been validated for outpatient joint arthroplasty. And the ORA score in blue compared to the ASA score in red is much more predictive and whether patients will be able to go home same day or next day after joint arthroplasty. So there is a tool out there. We do not use it at the University of Virginia. It's a little complex in the screening. We have different criteria, but it is there for people's resources. So what we're trying to do is to not select patients to have outpatient joint arthroplasty that will not be dischargeable same day. At UVA, we sort of have some criteria based on patient comorbidities, as well as some social criteria, and things like chronic pain or substance use disorder, patients potentially needing blood products, patients needing invasive monitoring as exclusions for our outpatient site. Just for your interest, we don't use age as a cutoff. We initially said 80, but we have a lot of healthy 80-year-olds that are perfectly appropriate for outpatient joint arthroplasty. So that's no longer on our list of exclusion. But the important thing, I think, is having some protocolization of what patients can undergo surgery at your outpatient joint facility, or potentially go home same day. The other thing I just wanted to mention briefly is preoperative protocols. It's really important. I talked about screening, also optimization. I don't have enough time to really go into that this morning, or this afternoon, but really optimizing patients, making sure that they're ready for a relatively high risk, potentially could be a high risk surgery. Educating them, so all the way from the pre-op to the discharge time is really critical, and that can be in the form of joint classes, reading materials, videos. We do all of that at our institution. We also actually bring patients in and we have them tour the facility so they can see where they're going to be having surgery. The other thing to just mention is that patients need to have appropriate expectations, as well as their family need to. So nothing will derail a patient going home, same day outpatient, same day joint arthroplasty, more than an anxious family member. So this is really important to make sure that everyone's on board. The other thing I wanted to mention is that education pre-op is critical. This was a systematic review of 37 studies. And what they showed was that educating patients preoperatively about outpatient joint arthroplasty not only decreased their pre-op anxiety, obviously, but it also decreased their post-op pain and their length of stay. So all really important outcomes for outpatient joint arthroplasty to be successful. So just to sort of recap the pre-op considerations: patient selection, really important, patient optimization, patient education, and then having good perioperative communication so that patients know how they can reach out and ask questions. So with that, I'm going to hand it over to Dr. Dealing, who's going to be talking more about the pharmacology multimodal aspects.
Thank you, Ashley. So I'm going to be talking a little bit about perioperative pain management. So obviously this is a key component to ensure that these patients are be able to successfully discharge home the same day. There's a systematic review that showed the top 3 reasons for failed same-day discharge in total joint ambulatory patients were nausea, hypotension, and pain. With pain accounting for 22% of discharge failures. Nausea accounted for another 16%, which again just emphasizes why both pain and nausea, by limiting opioids and having a multimodal approach, is key. So a successful pain management protocol for ambulatory total joints is multimodal in approach. It minimizes barriers to discharge and also limits the use of opioids, and overall, we want to maintain mobility to promote ambulation. So what works for these patients? So for the next part of our talk, I want to talk a little bit about the options for both pharmacologic and non-pharmacologic therapies that have good evidence specifically in ambulatory total joint arthroplasty patients. So we'll be talking about opioids and non-opioid drug classes, acetaminophen, COX inhibitors, and then later we will get into local and regional anesthesia techniques. So the first thing that I want to talk about, which is definitely something that we have in our ERAS protocol, is acetaminophen. It obviously acts by inhibiting the central prostaglandin synthesis and also has minimal effect on peripheral COX enzymes. There is a systematic review and meta-analysis that looks at over 1,200 publications. It's shown that acetaminophen in these specific patients reduces post-op pain and opioid consumption during their hospital stay. There's moderate evidence for pain management, strong safety evidence, low cost, low risk. And there's also existing evidence that supports the use of acetaminophen in ambulatory total joints, but the route of administration, PO versus IV, does not have an effect on their efficacy. So for acetaminophen and total joint protocols, you should definitely just say yes. It's safe, it's effective, so just say yes. So the next we're going to talk about is our nonsteroidals. There's a database study of over 500,000 total joint patients, and NSAIDs were found to have the greatest effect on analgesia and opioid prescriptions compared to other non-opioids. There is a systematic review and meta-analysis of COX inhibitors looking in ambulatory total knees that showed that their VAS pain scores at rest were significantly lower when they received COX-2 inhibitors. They also had improved VAS scores during flexion, and there was a significant difference in opioid consumption. There's one study concluded that all NSAIDs, when used in the short term in total joint arthroplasty, did not increase the risk of GI bleeding unless they were combined with other anticoagulants. So gabapentinoids. So the studies on the efficacy of gabapentinoids for perioperative analgesia are mixed. And then studies specifically for ambulatory total joint patients, it's basically absent from the literature. There's some systematic reviews that found benefit of a single dose of either oral gabapentin or pregabalin, did show some improved pain scores and opioid consumption at 24 hours. But there's another meta-analysis looking at 12 studies that found no significant analgesic benefit with pain scores, opioids, and knee flexion when comparing to placebo. So there's no evidence to support its routine use in ambulatory joints. There's obviously concerns for sedation, particularly in the elderly, concerns for respiratory depression. You have to be cautious when combining it with opioids. So at one point, this class of medications were part of ERAS protocols, but based on the literature, at this point, we're never getting back together. So ketamine, another option for ambulatory total joints. It's a non-competitive NMDA receptor antagonist. There's a randomized control trial looking in total hips that demonstrated the perioperative use of ketamine decreased opioid consumption at 24 hours, facilitated rehab at 1 month postoperatively, and decreased chronic pain at 6 months. There is a systematic review that shows high quality evidence for decreased post-op pain and opioid consumption, and also found that ketamine was not associated with an increase in adverse events and may reduce post-operative nausea and vomiting. Obviously, with ketamine, we do have to be cautious, especially in high doses, that we don't have any side effects that could potentially limit our patients from being discharged home the same day. So dexamethasone, it's a long-acting corticosteroid with multiple potential uses in the perioperative period for ambulatory total joints. In lower doses, like 4 milligrams, it can be used intravenously for its antiemetic properties. It can be used as an effective additive to perineural injection of local anesthetics to extend the duration of single-shot peripheral nerve blocks. There's a randomized control trial that demonstrated increased discharge readiness and decreased morphine consumption in doses of 8 milligrams of IV dexamethasone compared to placebo. And it found no difference in complication rates. And then there's a meta-analysis that found dexamethasone at doses more than 0.1 mg per kg to be an effective analgesic adjunct. So obviously with these patients, you have to use it in great caution if you're looking at type 1 diabetics, especially if you're doing doses higher than 4 milligrams. And lastly, so opioids, they continue to be a mainstay of analgesic protocols for total joints, whether you're doing them inpatient or outpatient. We do know that the use of 2 or more modes of analgesia compared to an opioid-only regimen has resulted in improved outcomes with decreased length of stay, lower odds of respiratory complications, and lower dose of opioid prescription on discharge. There is one study that shows that ambulatory total joints, interesting, are prescribed a similar amount of opioids on discharge, but they have significantly less risk of becoming persistent opioid users compared to inpatient total joint arthroplasty patients. So I'm going to hand it off to my colleague now to talk about some of the regional anesthesia options and the age-old question of general versus spinal. So this is Matt Thames.
Thanks. So we'll talk a little bit about our procedural options to add some analgesia here. The first being local infiltration analgesia performed by your surgeon. And this is, as it sounds, typically a large volume of dilute local anesthetic. Our surgeons mix in some epinephrine and ketorolac, and is injected under direct visualization in the OR. One of the benefits of that is that it's motor sparing. And there is also some good evidence in hips, especially, probably more commonly done in hips than knees, that it provides superior analgesia compared to just systemic medications. We know it's not going to be all encompassing, especially in knees. There's evidence that the addition of a peripheral nerve block provides better analgesia than local infiltration alone. And since it is World Regional Day, let's talk about why 2 is better than 1, and combining these things makes sense. So moving on to the blocks, consensus statement here from the Icarus group in 2021, generally advising that peripheral nerve blocks should be utilized in primary knee and hip arthroplasty. Interestingly, recommendation was based mainly on the not just the analgesic benefit, but the fact that there are lower complication rates overall when a nerve block is a part of the anesthetic plan. So which nerve block to do? The innervation of the knee is fairly complex and a topic for another lecture entirely, but our first and foremost concern is we don't want to be blamed for a motor block that's going to negatively impact the patient's ability to do rehab right after surgery, or God forbid, have a fall after surgery. And so we'll eliminate from consideration the major motor blocks from this group and just consider the motor sparing blocks. For us, the winner of this is the adductor canal block. That's performed at the mid-thigh, technically probably often the distal femoral triangle. Biggest target there is the saphenous nerve, but based on its proximity, in our group, we typically also add local anesthetic next to the nerve to the vastus medialis, a little more laterally under the sartorius, as well as the anterior femoral cutaneous branches located in that plane right above the sartorius. So that spot is by far the biggest bang for the buck, if you will. And so that has been officially protocolized in our ERAS pathway. With some variation, we do add either geniculars and or IPAC blocks, a little bit more of a provider preference, patient-specific situation if we feel those are warranted. In terms of the options for hip arthroplasty, again, they're numerous, but we'll eliminate the ones from contention that would cause a significant motor block. I'll often, directly say to patients that I don't think there's a great block that takes away a ton of the pain without causing you some motor weakness. And so for that reason, we don't have nerve blocks written in to our protocol for hip arthroplasty, but we do them occasionally and sometimes take the strategy of consenting for a post-op rescue block. When we do that, typically the most common block we would perform is a PENG block, a pericapsular nerve group block, again, with the primary benefit being that it is motor sparing. Similar probably efficacy to local infiltration analgesia, but I would say anecdotally that sometimes that's the difference between a patient getting comfortable enough to continue on with physical therapy and even go home the same day. So now the many of us know all too well this debate, the spinal versus general debate, still a topic of very frequent publications, even in the last few years, more and more publications about which is better, spinal or general for total joint arthroplasty. Big landmark paper initially being back in 2013, which came down on the side pretty squarely of neuraxial anesthetic being favorable due to lower complication rates while in the hospital, lower mortality, length of stay, pretty much setting up the spinal to be the gold standard for joint arthroplasty for hips and knees. And that makes sense. Instinctively, there are numerous benefits to a spinal compared to general anesthesia, specifically, typically less effect on the pulmonary system. We avoid some of the negatives of general anesthesia, such as instrumenting the airway, post-op nausea, vomiting, and less strength of evidence, but certainly some that in certain patients may prevent postoperative cognitive dysfunction, may have lower rates of thromboembolic side effects, or may have some evidence for decreased length of stay. That's not to say that spinals are perfect. Of course, we do have to consider some of the potential side effects or drawbacks. Lump these two things together, TNS and post-dural puncture headache, just by saying that both of them are are fairly significant morbidity, but thankfully very rare with our current practice in terms of what local we use and the spinal needles that we use. So less of a concern typically, but especially in the outpatient population or the outpatient setting where efficiency in the OR matters, there is more variation in the time to perform this procedure than there is in simply induction of general anesthesia. And of course, the PACU stay also becomes a big concern in terms of getting that spinal dose and timing just right so that it wears off without too much delay and the patient has motor function to proceed with physical therapy. Post-op urinary retention, probably one of the biggest concerns here in terms of prolonging PACU stay as well. So consensus overall for total hip and knee arthroplasty, again from the Icarus group here, is to recommend neuraxial over general anesthesia for primary hip and knee arthroplasty. And that's due to the fact that in pretty much all reported categories of complications, there were lower odds or no difference for the spinal group. And that was true for all those categories except urinary retention. So again, that's one of still the last things to keep in mind as a drawback from the spinals. But that's for joint arthroplasty overall. And today we're focusing more on the ambulatory population. And in the ambulatory setting, there are very few publications actually comparing directly the two. Here are two of them here. And I would summarize by saying there's no significant difference shown in complications. This is makes sense because in the outpatient setting, typically we're a lot more selective in terms of selecting patients who are less likely to have complications overall. And so there doesn't seem to be much of a distinguishable difference in complications between your route of anesthetic. Potentially a little bit more pain in post-op with the GA as opposed to the spinal, but certainly possible to accomplish same-day discharge for both methods. Potentially a little bit more success or higher success rate with a spinal anesthetic than a GA. Our winner here is a mepivacaine spinal. We typically do about 60 milligrams, and that duration works very well for our surgeons. Of course, that's essentially the factor you have to titrate to the length of your spinal too. So there are institutions probably able to use chlorprocaine with or without an additive for very fast surgeons. The biggest or most important thing here is that for recovery-wise, you want a local anesthetic of short to intermediate duration, which means that bupivacaine here is not going to be your friend due to the prolonged effects of motor blockade in the recovery room is the biggest thing there, which would prevent the patient from proceeding down the pathway. So I'm going to hand things back to Dr. Schilling, who will summarize a little bit and help conclude your tour through our ERAS pathway here.
Yeah, so just was going to summarize, thanks for sticking with us. The most important components of outpatient joint arthroplasty begin in the preoperative period with appropriate patient screening, optimizing them, robust educational components of the process. And then in the pre-op area, these patients get acetaminophen and they get a COX-2 inhibitor. Intraoperatively, as Dr. Thames mentioned, we do a mepivacaine spinal. Other options, you know, if your surgeons are a little faster, chlorprocaine certainly, but we do mepivacaine because we are a teaching hospital, no adjuncts. Patients get about 1 liter of fluid when fluid is available to us. With the shortage, maybe less lately. Ketamine and magnesium, we add to that. They get pretty aggressive PONV prophylaxis. Occasionally we'll get opioid intraoperatively, but oftentimes not. And then our surgeons supplement our blocks with the local. And then postoperative protocol is really emphasizing early PO fluid intake, working with PT as soon as the spinal is worn off. And then, you know, occasionally our patients do, you know, typically do get some opioid orally before they go home. We've required them to void before they go home. They get a really robust, like I said, education before they're allowed to leave. Ice packs or ice machine, and then they're discharged home with oxy, Tylenol, and a COX inhibitor. And then we continue to communicate with them, you know, throughout this process up until 6 weeks after. So this is a summary of our protocols at the University of Virginia. And ultimately, you know, we really think that multimodal and regional techniques help our patients to have swift recoveries. So with that, I guess we're all running a little behind, but if there are any pressing questions or anything, and I'm going to bring my friends back in just for the goodbye.
Thank you so much.
Thank you.
great presentation. And I know, it's always nerve-wracking to start an outpatient total joint program, but I'm glad you guys are seeing success with it. Any tips for people trying to make the jump to an inpatient? What is it that you would say that helps make that transition to going to a fully separately removed location for outpatient total joints?
Patient selection.
Yeah, I mean, I think success starts with picking the right patients. And I mean, I think if you're starting fresh, being a little bit conservative about what patients you're going to do until you really learn your environment and learn your staff and get comfortable. I think we were more conservative when we opened up 2 years ago, but I think consistency, having surgeons really buying in, and the teamwork of the whole process, physical therapists, our nursing colleagues. So it's a big, huge lift for everyone involved. But I think for us, really thinking about the appropriate patients to have this surgery as an outpatient.
I placed a question here at the bottom of the screen. How long does motor function take to return after mepivacaine spinal, and discharge time for same day? Does location of the block, subarachnoid block, affect response with mepivacaine?
Yeah, so our mepivacaine spinals, our surgeons take about an hour to an hour and a half for their joints, knees and hips. And so we typically use anywhere between like 55 milligrams to max 60 milligrams. And then we bring our patients out. They're usually moving already once we get them to, push them to recovery. And within an hour, it's almost always fully resolved and they have full motor. Now, voiding typically, as we said, is the last thing to return. So it usually takes a little bit longer, but I would say we target L4, L5, probably most routinely for our spinals, and 55 to 58 milligrams of mepivacaine is pretty standard for our practice.
Yep.
And we have 2% mepi, so that 3 cc volume typically spread such that I don't personally change the location, whether it's a hip or a knee, or worry too much about the location, whether they have a good space at L4-5 or 3-4.
Excellent.
Yeah, very similar to what we do here. Thank you guys. And you guys inspired me. I had to go search out a good quote for the end of this. From Wildest Dreams, nothing lasts forever, but this is getting good now. So, thank you so much. Really appreciate you guys, and great to see you.
Thank you all.
All right. What a wonderful presentation.
Fantastic.
Yeah. So we are going to be playing a video of a presentation, but we have Dr. El-Sharkawi here with us to just kind of say hi briefly at the beginning. We recorded this presentation ahead of time so we could get all our timing right. But hey, Hashem, how are you?
Hey, how are you doing, everybody? Thank you for having great presentations, a great group. What an amazing idea, amazing opportunity to see different friends, colleagues all over the world, all over the continents. I'm trying to go between the continents.
I know, it's amazing.
It's really amazing. It's really amazing opportunity, but glad to be with you. And my name is Hisham El-Sharkawi. I practice at Metro Health at Cleveland. I'm also professor of anesthesia at Case Western University. And I'm going to present you the different topic, a little bit like shifting gears from medications to other blocks to like a neuromodulation. And then neuromodulation have a role in all the time, in the chronic pain, but recently it have been like shifted to the acute pain. So we'll present like a different topics from acute pain to also some new chronic pain indication to non-pain indication even. You're going to see with the presentation, and it's only not from one institution, institution, and also Vanderbilt and University of California, Davis. We have two great experts also will present. So all of us looking for a discussion, happy to answer any questions if there is a time.
Yeah, and we are a little behind on time, so I encourage people to put questions in the comment fields of your video, and then we can all answer them independently by text messages. We may not have time for direct questions at the end of the video. The thing, just so to preview what's coming, so Dr. Grant is going to be doing his live scanning right after this video, and then we have one more video from our colleagues at Mayo Clinic to wrap up the session from the ASRA Pain Medicine group. So Thank you, Hisham, for being here. I'm going to put the video up on the screen. We'll get all of us off the screen and we'll let the show start. Okay?
Great.
Thank you.
My name is Hisham Al-Sharqawi. I'm a staff at Metro Health Hospital in Cleveland, Ohio, and I'm a professor in anesthesiology at Case Western University. I'm glad to be here with you, and thank you very much, Ezra Society, for the great opportunity, and looking forward to meet and connect with all over our colleagues and experts across the globe. What a great opportunity for all of us to meet, interact, and learn from each other, from experience, personal experience, and also institutional experience. So without further ado, I have the pleasure to introduce two of my esteemed colleagues, experts. All of us will learn from them. Dr. Raj Gupta, he's a professor of anesthesiology at Vanderbilt, and also Dr. Scott Britzleff, he's an associate professor at University of California, Davis, and we'll talk about the peripheral nerve stimulation. And we'll start with Dr. Raj Gupta, gonna describe some indication for peripheral nerve stimulation, especially with the acute pain settings.
All right, thank you. I'm going to start by just doing a brief introduction of peripheral nerve stimulation for acute pain management. We have a short time to talk today, so I won't be able to go into full detail, but I want to give you a sampling of what's being explored in this area. Neuromodulation and nerve stimulation, nerve activation has been explored in chronic pain for quite some time, but I think there's a growing interest in acute pain management because there's a need that we're seeing that acute pain is not fully managed into the postoperative period as well as we would hope it to be. So this is where exploration is happening right now. Indications and contraindications and actually the logistics of doing this are still up in the air. I want to start by just saying that, in my opinion, peripheral nerve stimulation will be the next advancement in acute pain. Well, possibly. And I would say potentially based on the data that we're seeing. So there's a lot of caveats to this, and I think that's really important to talk about. So disclosures, I have none related to this talk. I am a director at large at the ASRA Pain Medicine Board of Directors, and I'm also the lead developer for ASRA's COAGS, LAST, and Timeout apps. So let's talk about what peripheral nerve stimulation for acute pain really means. Many of us have done nerve blocks, nerve catheters, where we put a needle next to the nerve and bathe it in local anesthetics, or we put a catheter next to the nerve and allow that pump to infuse local anesthetic next to the nerve. With peripheral nerve stimulation, what you're doing is taking a lead and putting it near the nerve. And one of the things we'll mention is you actually don't get even as close as you do with a nerve catheter to the nerve. It works better when it's a little bit further away and it's less uncomfortable for the patient from a motor stimulation effect or other side effects. The first ones of these were done using spinal cord stimulators. These were very delicate leads that were put near the nerves, and they worked, but unfortunately they were a bit fragile. Sometimes they broke. They're expensive. They're not really made for this indication. Newer leads have come out that are a little bit more stable, more reliable in those places, but still tend to be on the fragile side, especially when you're thinking about leaving these leads in for a week, 2 weeks, 4 weeks, or longer. It's really important to have something really stable and structurally sound. Now, what happens is these leads are connected to a pulse generator that's often adhered to the skin. This has a battery in it. Some of them are fixed generators. Some of them have some adjustment ability to them, and they drive a current down that lead adjacent to the nerves, providing a neuropathic benefit. Just like all neuromodulation, variety of theories out there, the primary one being gate theory to reduce the nerve stimulation. And the indications for this in acute pain are starting to be introduced, but haven't fully been developed. And we'll get back to that. So here's another diagram showing, the standard stimulator lead, which is connected to the stimulator on the left. You have a little microelectrode that's placed several, 2 centimeters away from the target nerve and is driving a pulse signal intermittently to the nerve to get that effect. There is an alternate way to do this, and this is sort of a retroactive way of doing this, is using an existing nerve catheter that has a stimulating electrode at the end, just like we would use for electrical stimulation for identifying a nerve, you can use the same stimulating tip to drive electrical current to the nerve. And we'll talk about where this was used and how it might be valuable in this situation. But this is a nerve catheter. It just has the stimulating tip at the end. So what's been done with this? So the interesting thing about this is most of the data on neuromodulation, peripheral nerve stimulation for acute pain comes primarily out of one institution in San Diego and one research team. And so we have to be cautiously optimistic, but cautious about interpreting this data. It can be, needs to be reproduced by other institutions, and we need to see how a variety of patient situations will allow this to work or not work. So this is an example where they had two groups of patients, an upper extremity group and a lower extremity group. The upper extremity group had a stimulator placed along their brachial plexus for rotator cuff surgery. The lower extremity group had one placed around the sciatic nerve, and this was either for hallux valgus surgery, ACL, or ankle surgery. The patients would get a single shot nerve block, 0.5% ropivacaine, 20 milliliters for postoperative pain, and then the stimulation would start in the postoperative period, and they had up to 14 days of stimulation. Sometimes it was a little bit less because the lead would fall out or break or the patient couldn't tolerate it. They had a total of about 66 patients, but actually in some of the subgroups, it got to as small as 8 patients in a certain surgical category. So we have to be careful of interpreting this data with such a small sample size. What you can see on this is looking at oral morphine equivalents on this graph. And in the left-hand side, they broke it up for the brachial plexus group, on the right-hand side for the sciatic nerve group. And in this chart, you see that the red line represents the stimulation group and the blue line is a sham group. So this was a true sham. They did put some lead in the patient, but there was no stimulation occurring. And you can observe that during the intervention period, there is a significant difference in opioid consumption in the patients who had stimulation in both categories, a little bit more profound in the brachial plexus group and more long lasting, but it's present in both. Of note, though, you do notice that when the stimulation intervention is gone, that both groups end up at about the same place, which is that they don't need opioids that much after about 10 days out or less in the lower extremity group. If you look at this same population at their pain scores, similar kind of phenomenon. The red is the stimulation group, sham is in blue. And you can see in the brachial plexus group that the pain scores do consistently stay lower throughout the study period, throughout the intervention, but they also stay lower in the post-operative period. And they've even measured these patients out to 30 days. So there is a difference that they've observed in these two sample groups. In the lower extremity group, that curve does bend back down to almost equal after about 10 or 11 days. It doesn't extend out to the 30 days, but there is a difference during the stimulation period. What I interpret when I look at this is, yes, there's a difference, but how much? So in the pain, you're looking at about 1 to 1.5 points of difference in the 10-point scale. In the opioids, you're looking at differences in the 10 or 15 milligrams or less category. So we have to think about that when we talk about the impact of this therapy. And then if you look at pain interference, so this is how it affects their day-to-day life. Again, you're seeing the same thing. You're seeing a difference between the stimulation group versus the sham group, but that at 30 days, it goes back to about the same. And then the lower extremity, the benefit is more rapidly reduced than it is in the brachial plexus group. This is another study group. I told you that it's important that we look at other groups of data sets. This is a different group looking at amputation. So this was either transtibial or transfemoral amputations. These patients actually got femoral and sciatic nerve catheters for 5 to 7 days, running ropivacaine 0.2% at 10 mLs per hour. And then the stimulation wasn't started until 24 to 48 after the peripheral nerve catheter was discontinued to allow the local anesthetic to fully wear off. And they ran these patients with stimulation for up to 8 weeks, so much longer duration. Now, this is a small study, total 16 people in the study, 8 in the treatment group, 8 in the placebo group. But when we look at this data, we see that this effect of the stimulation, especially when it's continued out for 2 months, does provide a difference. So on the top left graph, you see proportion of the subjects who are using opioids. And you can see that the stimulation group was actually using some more opioids than this control group before surgery. But then after surgery, there is a significant reduction in opioid consumption. In the change in the average opioid, these are oral morphine equivalents from pre-op to post-op. Same look at this data, but you see that there's a decline in the stimulation group from their baseline. And then the last is the average opioid use. This is less dramatic. They start out pre-op using quite a bit more in the stimulation group, and they come out to roughly the same on average per day use when you get to 3 months out. But again, we're seeing a benefit here. The question is, what is the scale of the benefit? One other example I want to give. So I showed you the peripheral nerve catheter that had the electrode on it. So one study group out in Canada, what they did is they took someone who had a peripheral nerve catheter in, but started noticing that their pain was increasing like a day or two into their postoperative period. They stopped the infusion, and then for a short period of time, so several hours, sometimes 4 hours or less, they turned on the stimulation, noticed a significant drop in their pain scores, turned off the stimulation, returned the catheter to infusion. And they actually had a reduction in their baseline pain. And then when the pain started increasing the next day, they did the stimulation again for about 3 or 4 hours. And then they had a reduction in pain and then started the infusion back up. So this was just a case report, but it's a novel demonstration of how you can use the stimulation in a sort of non-traditional sense to provide neuromodulation in a patient that's already having traditional therapy with a peripheral nerve catheter. So, I don't want to go too long about it because the studies are all kind of showing the same thing, that we do see benefit from the peripheral nerve stimulator in acute pain, but there's a lot of logistical complexity. So in some situations, they describe a protocol where the patients would come in the day before surgery to have a stimulator put in, and then they get a block on the day of surgery or a catheter, and then the stimulation is started at some later time, and that has to be monitored, or the stimulation modality has to be changed over time so that the patient is receiving the right benefit. We still don't know yet what the right programming is for these stimulators. We don't know what kind of stimulation style. We've noticed that in the chronic pain world, there's been a lot of work done on how stimulation is provided to nerves to get the maximum benefit and to avoid the tachyphylaxis that occurs over time. We don't have that information in the acute pain world yet, and there's a lot of work that needs to be done. There's a lot of inconsistency. One of the things that I didn't point out on those charts is you'll see significant outliers. You'll see people whose pain is quite a bit worse with the stimulation group than it was at baseline. So this doesn't work for everybody. Is that because the placement was wrong? Is that because the setting was wrong? Is it because the wrong nerve was stimulated? Is there something more complex going on there? And then we don't have a full deep dive time to talk about cost, but cost is an important consideration. I talked about the absolute benefit of 10, 15, maybe 20 milligrams of morphine equivalents that are saved or preventing the patient from receiving those in the course of the treatment period, or a couple of points, point and a half of pain score reduced. Well, the cost of one stimulator need and a generator is going to be roughly about $5,000. Now that hasn't come down yet. And the question is the system willing to bear that level of cost for that level of benefit? When we looked at the amputation example where they ran the stimulation for 2 months, maybe that equation changes. But for acute pain for a rotator cuff, that equation may be very different. Or the devices become less expensive. Or we have the situation that we described with the case report where we're using existing technology and temporarily providing neuromodulation to adjust the trajectory of pain. So there's a lot of possibilities in this. And the last thing to mention in this is that we don't know exactly what the timing and interaction of our local anesthetics versus electricity and how those two should be used together, in what timing, in what dose, and for what duration. And I think that's going to be a big question in the acute pain management world as well.
So again, my name is Hisham. So I shift the gears a little bit to the chronic low back pain. And this is my disclosure and some of the product that I may mention during the lecture. So I do some consulting for them, but I will not go into too details about the research or result of the studies, mainly in our experience in our centers, and a little bit of new ways to look into some of those well-established indications already. So chronic low back pain is very common, very costly problem across the whole world. And I'm talking specifically about the chronic low back pain, the non-surgical pain, just below the costal margin, no radiculopathy, and newly they're trying to refer to as a non-surgical refractory back pain, or the persistent spinal pain syndrome type 1, that the patient doesn't have a spinal surgery before. Very costly issue across the world, loss of productivity, and also with many modalities that are available, and the patient fail injections, fail medications, fail radiofrequency ablation, physical therapy, multiple modalities. And a lot of those patients get frustrated and they started to lose hope in the treatment and lose hope in us. And one of the mechanisms of those patients that the patient started to lose muscle simply. And it's a lot of this coming from a mechanical musculoskeletal impaired control. So when any patient have any pain across any joint in the body, actually, this joint lead to a reduced activity. So you avoiding moving this joint, you lose control of the muscle around it, or the nerve supply of this muscle get decreased, and then this muscle get atrophy, and this lead to instability of these muscles that are around this joint, lead to like a vicious circle of what they name it like arthrogenic inhibition there. So the idea of restoring the muscle tone back again will break this cycle and bring the patient pain like down gradually. So it's a kind of a different way of delivering stimulation. It's not like a peripheral stimulator to decrease the conduction of pain signals. It's restorative neuromodulation, or like a muscle stimulation. So the available system, the temporary system that Dr. Gupta touched base with, it's a temporary system used for only 60 days, and you use a long monopolar electrodes. It's very thin, very small, and this lead to fibrotic ingrowth when we implant it for only 60 days. And this fibrotic ingrowth that around the tip of the lead help stabilizing the lead, preventing maybe migration, and also prevent or decrease the risk of infection. And the idea here, it's different than destruction RFA, and it's not a permanent implant, it's just a temporary implant. There is other system also that many across the world use it, which implantable system, permanent system with the IPG to also as a restoration. And we use kind of a close target around the L2 for the L3 for the L2 dorsal ramus. What is a relatively new, in the center that I've been using, I have some evidence, but not strong evidence, but in the same idea that myself and others have a lot of work within the regional anesthesia world about facial plane blocks and the localization of the nerves and the facial planes. So I try to translate some of this work that have been done within the regional anesthesia world into the peripheral nervous stimulation world in trying as a restorative mechanism for multiple indications for the back pain and others also. So as we know that the multifidus muscle, it's one of the core stabilizing muscle of the back, but it's not only the multifidus muscle. There's longissimus, the iliocostalis, and transversus abdominis muscle, and there is other muscle that also act as a stabilization for the spine, and they can contribute to the low back pain. So just in this image, this is the standard approach, especially for the temporary devices that use to stimulate only the multifidus muscle, where we go medial to the facet joint and just lateral to the spinous process. And the aim is to try to stimulate only the multifidus muscle. But I also like question why only the multifidus muscle. It's the most important, but it's not the only one. There is other muscle that I mentioned before that also can help stabilizing the back, the longissimus, iliocostalis, transversus abdominis. So by putting the lead, for example, in the left side around the main dorsal nerve, and you're looking for stimulating the whole erector spinae, not only the multifidus muscle, you may get a better outcome. Do we have a data? Just a preliminary data that I presented an abstract before in the European Society of Anesthesia, and this actually also recently in our research day at my institution won the best abstract. Other also options in the right side, not only for the lumbar multifidus, in the thoracic area also, around the dorsal ramus, the main dorsal ramus, as you see in the X-ray image in the right lower corner, to stimulate the main dorsal rami, to stimulate the thoracic erectorospinal muscles, deep to the rhomboid muscle in this tissue plane, and also laterally around the lateral cutaneous branches to stimulate the latissimus dorsi, and even lower, you can stimulate also the transversus abdominis muscle. And the left side, a lot of those patients with also chronic low back pain, axial low back pain, non-radicular low back pain, we can use a colonial stimulator, either permanently or temporarily. And the location where the colonial nerves over the iliac crest, it's simply posterior to the quadratus lumborum muscle. So this also work that the regional anesthesiologist, acute pain physician comfortable with. It's the same location that we implant our colonial stimulators. How about the neck? Also, a lot of patients have a neck axial non-radicular pain, and they failed injection, they failed cervical medial nerve branch radiofrequency ablation. And then what's next step is also stimulating those branches, either the main branch, the cervical medial nerve branch, or some of those terminal branches of those nerves. It depends on the vein location. It's also possible using X-ray, using ultrasound, and as you see in the images in the right lower corner, where with the X-ray stimulating the cervical medial nerve branch just lateral to the, for example, some pedicular screws here, and also for the occipital nerve at the C2-3 area. To close, also there is some others which can be used modalities, and we use it in our institution for axial pain, non-radicular pain, a spinal cord stimulator, but here I'm talking about a ventral lead. Ventral lead that while we're implanting our spinal cord stimulator, we're trying to avoid putting the leads ventrally to avoid motor stimulation. It actually have a role. You can intentionally put the leads in the ventral spinal cord, like in the image in the left side, and use like a high frequency stimulation to stimulate the lateral spinothalamic tract to get a sensory, and you can use it to use a low frequency and get a motor stimulation that we're trying to avoid in the thoracic or even lower extremity. It depends on the level of the pain, to intentionally do a motor stimulation as a rehabilitation, and indirectly it can have an analgesic effect. Touch base on the vagus nerve stimulator, and my colleague Dr. Pretzlaff will discuss this, but a lot of chronic low back patients, they feel conservative, and then they start to have a chronic generalized pain. They get depression, anxiety, they are catastrophizing, and in addition to the chronic low back pain, that feel conservative. So there's a maybe potential for a vagus nerve stimulation. Either there is definitely surgical, and there is definitely transcutaneous, but also there's maybe potential for a percutaneous vagus nerve stimulation using X-ray and ultrasound, and you see in the image. We have been using it successfully, but we don't have a strong data for this. So in short, especially for the low back pain, the failed conservative, low back pain without radiculopathy, non-conservative, and failed conservative, and non-surgical, and failed all conservative, I would start to consider stimulating the whole erectorospinal muscle, and also other stabilizing muscle of the spine, not only the multifidus muscle, and consider this early in the care path, and give the patient choice, because sometimes we don't have a strong evidence in the literature, but give the patient choice which route he wants to go, into destructive radiofrequency ablation and just injection, or maybe rehabilitation of the muscle and get him back to be active and more contributing and to like activity, and also with less impact in other like his work and using medications and with the side effect and other.
I'm going to speak about, I think, something that's a little different in the sense that, as a pain physician, we're used to treating pain. And I think what's interesting about the expanding indications for peripheral nerve stimulation is that there is an evolving field to use this technology for non-painful conditions. And so we will discuss a smattering of some of these. My disclosures, I do a lot of work in the PNS space, and that's reflected in my disclosures, as well as some education grants from some of the neuromodulation companies and royalties as well. So I think the first thing we will discuss is the idea of using peripheral nerve stimulation for overactive bladder. It's not a novel concept to use neuromodulation for overactive bladder. That's existed in the urology literature for some time. But it is a little unusual to make the case that stimulating the posterior tibial nerve can be effective for overactive bladder. And so the next question I always get is, what is the mechanism? And the mechanism is that the proposed mechanism is that you are stimulating some of these afferent fibers of the posterior tibial nerve, which synapse and are contributors to the sacrospinal cord and the sacrospinal anatomy. And by providing afferent input, you can essentially decrease or interfere with micturition reflex signals, therefore decreasing overactive bladder symptoms. And so what's interesting about stimulating the tibial nerve is this has been done several ways, both from a transcutaneous perspective, essentially in some ways almost like you're using TENS pads in that area, to a temporary percutaneous approach with a needle that's done in clinic for a brief period of time. Patient comes in, say, weekly, to something like this, which I think speaks to the evolving technology of posterior tibial nerve stimulation. This essentially resembles a watch battery. And it contained in this stimulating device is both the cathode and anode, which is also the battery itself, and can be implanted directly onto the posterior tibial nerve just above the tarsal tunnel. And the patient has a controller, but this device essentially functions autonomously, stimulating for about 30 minutes every day. And depending on the needs of the patient, could last anywhere from 1 to 8 years. And this is just but one form of posterior tibial stimulation for overactive bladder that exists. But it's interesting because something that is minimally invasive, that can be done in a very short period of time, the meta-analysis of the literature shows that for patients who have dry overactive bladder, meaning they're not consistently incontinent, that you are improving voiding frequency and maximal voided increasing maximal voided volume. So patients are able to empty their bladder better, and they are able to decrease the amount at which they need to void. And so this is really cool technology and something that can treat a whole host of patients who are out there with a modality with which we're very much familiar in the chronic pain space. Which brings me to some of the fringes, but I think it's important because this, once again, is an evolving indication. Patients who have intractable hiccups, and Brian Mariscalchi at Vanderbilt recently had a really good case report that was published in Regional Anesthesia and Pain Medicine this past year, looking at a temporary percutaneous system implanted on bilateral phrenic nerves in a patient who had refractory hiccups, showing fairly good benefit. And I juxtapose and put on top of that this whole idea of vagal nerve stimulation, which I'll show you some images. Keeping in mind this is an off-label use of implantable vagus nerve stimulators, but nonetheless, a really good case report that included Philip Peng, very well known to ASRA and many of the international regional anesthesia societies, just showing how patients can be treated both with either phrenic nerve stimulation or vagal nerve stimulation with refractory hiccups. The case report that was published, they targeted bilateral phrenic nerves, and this was done with ultrasound guidance. And this patient showed notable decrease from a moderate to mild form of hiccups, and I'll show you that frequency scale. Keeping in mind that vagus nerve stimulation involves a radically different system, these systems have been adapted for patients with refractory drug-resistant epilepsy, but have been used also for treating patients with refractory hiccups. Dr. DeBlue, who's a neurosurgeon, this group was out of Toronto. This patient responded very well and quickly to a peripheral nerve block of the vagus nerve. And just keep in mind, that block can be done with ultrasound guidance, pretty easily visualizing the jugular and carotid artery as that vagus nerve exists within the carotid sheath. And then subsequent to that, this patient, she went on to have a permanent system placed, just unilateral placement, the lead, I believe on the left side, and essentially had complete ablation and all of her hiccup symptoms stopped. Interestingly, there's actually been an assessment instrument called the HAI that was developed about 15 years ago that describes a patient's frequency of their hiccups. So for example, in the first case report, the temporary system, the patient went from moderate to mild symptoms. And the other case where the permanent vagus nerve stimulator was implanted, that patient went from severe to essentially none, to no hiccups. And keeping in mind that that patient, Dr. El-Shakari commented on it, that patient had suicidality and was extremely depressed. And that report noted that a lot of those psychiatric symptoms have dramatically improved following the improvement of hiccups as well. I just also wanted to comment and point out that in the neurology and neurosurgery space, there is good data to show the use of peripheral nerve stimulation and vagus nerve stimulation for patients with drug-resistant epilepsy. Hot off the presses, a 2025 meta-analysis that looked at a large swath of studies, including 9 RCTs, found that about half of patients experience greater than 50% reduction in seizures with their therapy. I also just point out that the leads are very interesting to me. As someone who implants both permanent and temporary systems, these are essentially 2 leads, so it's a bifurcated cable and little hooks that essentially wrap around in the carotid sheath where that the vagus nerve runs, and this is typically done unilaterally. So very interesting lead design, novel compared to some of the other devices that we are using. So just to summarize and comment what both Dr. Gupta and Dr. El-Shakari had also mentioned, I mean, where are we headed? We're headed to, I think, in a very exciting period of time where just the hardware for PNS systems is going to improve. Smaller wearables, a lot of these systems are paired with external wearables. And so I think it's only going to improve for both the implanter as well as the patient experience. Payer access is very important. And Dr. Gupta also commented on this. Cost is also incredibly important when it comes to these systems, driving down the cost and improving coverage for many of these indications. And then really exploring these applications. We had commented on acute pain. Craniofacial is another where many of the systems we use can be off-label for those indications, as well as something like PTSD, which Hesham, you also commented on. So a very exciting time for PNS, and I will hand it back to you.
Hashem, I don't know if you're still there, but I just wanted to thank you for the presentation. Excellent. Hey there, thank you.
Well, thank you.
Excellent presentation. I think it's going to spark a lot of curiosity and investigation by a lot of people. My big hope, and thank you for inviting me to help present that, but my big hope for this is that the cost of delivery goes down. And I think that the opportunities increase as we get to the cost of delivery and the ease of access for more patients. And then as we talk about a global community, that's going to be affecting the ability to distribute this to other countries too, where, these expensive modalities aren't really available to everybody.
Agree. No, I totally agree. I mean, the cost, and I think we have to be more precise about the indication. I think not every patient especially within the perioperative setting, or even with the chronic stages, with sometimes the conservative measures or a simple injection can work well. So driving the cost down with improving patient selection, I think will give us in a better place with data. We need data because out of this, very few data or evidence. So we definitely need data.
Thank you so much for being part of this. So really appreciate it. All right. We'll see you soon. Hey, Stuart. Hey, Monica. How are you?
Hey, Raj. How are you?
Can she hear me? I don't know if she can hear me.
She can't hear you. I can hear you, but Monica can't hear you.
Hey, Raj. Can you hear me?
Yes, I can hear you. Good to see you, Monica. Okay, I'm going to hand it off to you guys and go for your live demo, your multicam, multimedia thing.
we're gonna try. So we're gonna fantastic. So people have put in some suggestions.
You have a little bit of an echo going on in your audio.
I think that's because Monica and I are both on microphones. So
yeah.
Oh, you're getting echoes.
Yeah, I'm getting an echo. So you may have to mute one at a time if you're talking. I'm not sure how you want to do that.
Is that better now?
Yeah, it's a lot better.
All right. Okay. Thanks for that one. So we can do that. So I'll mute me when Monica's talking and the other way around.
Yeah, looks good.
Fantastic. So we had some comments, suggestions for live scans. We're going to cover a few things. We're trying to keep it down to 30 seconds. So we can't cover everything. 30 minutes. So we can't cover everything. It'd be great if we could do it in 30 seconds. But we're going to start with a new alternative. If you're doing a shoulder surgery and you can't do an interscaling, a lot of people will do a suprascapular nerve block. I've been combining it with an infraclavicular nerve block, but that blocks out the whole arm. So is there any way that we can do this a little bit more specific, a little more detailed? So Monica is going to talk a little bit about the something that's just published. It's head of print in Rapin right now. I don't think it's even in the paper edition. The coracobrachus subscapularis plane block that she has been working on. So Monica, I'll hand the audio over to you and you just tell me when you want to put up your slides.
Yeah, sure. I'm just going to go with a brief introduction here. So hi, everyone. It's very, very nice to be part of this celebration of World Day of Regional Anesthesia. I am Monica Nanda. I'm a professor of anesthesiology here at University of North Carolina Hospitals. And I have with me my fine crew here. I have my two fellows, Dr. Sam Gottlieb and Dr. Daniel Morgenstern. You'll get to see them here in just a second. And I have my other colleague, Dr. Brian Tran. He'll be scanning here in a few minutes as well. So we have a live scanning program for you. And in the interest of time, we will focus on just a few select blocks for maximum benefit. So first thing we will start with is a coracobrachialis subscapularis fascial plane injection, and we did a cadaveric dye study. So I'm going to give you a very brief primer as a PowerPoint, and from there we will go to scan this particular block. So what this is a block where we inject in the fascial plane in between the coracobrachialis and the subscapularis muscle. And the goal is to get the proximal branch of axillary nerve as well as the subscapularis nerves, the nerves to the subscapularis muscle. And when we did a dye study, we were able to demonstrate a good spread on both of these, on the proximal axillary nerve as well as the nerves to subscapularis. So we think it's going to be a good way to provide anterior shoulder analgesia in conjunction with a suprascapular block. So this is a position you want to externally rotate the arm and abduct it 60 to 90 degrees. The probe is going to be horizontal, and I'll show you how to scan this. We'll be in the infracoracoid area, and the needle will be going from lateral to medial. And this is the view to expect. You will see the pectoralis major muscle up top. The next muscle would be the coracobrachialis. The bony landmark is the lesser tuberosity of the humerus. and then the subscapularis muscle wraps up around it. So when you externally rotate the arm, you'll be able to pull this muscle more superficially to be able to give you a good view of this plane right here. And this is where we injected the local anesthetic, which showed a great spread to both the axillary nerve as well as the subscapular nerves to subscapular muscles. And that is a primary contribution to the anterior shoulder, along with lateral pectoral, which we cannot block with this particular approach. So this was a dye study picture. As you can see, medial is over here, lateral is here, and I'm picking up the posterior cord here, and this is the surface of the subscapularis muscle. And this is the axillary nerve with 15 mL of blue dye. There was a great staining of the proximal axillary nerve, as well as you can see these 3 nerves. These are the subscapular nerves. They were all very nicely stained. So with that background, let's go ahead and start scanning.
Right, there's the ultrasound. Okay.
Okay, so we have the ultrasound picture. And
so why don't you show
okay, great.
Patient,
Okay.
you're going to place the ultrasound probe.
Great. So I have left as lateral and right as medial. So I'm going to put the probe right. So the arm is externally rotated and abducted. And I'm going to put the probe like right on the just below the shoulder joint. And we will look for the lesser tuberosity of humerus. So I'm going to move the probe up and down until we get to see the lesser tuberosity of humerus. So this is down. I'm not seeing the tuberosity. I'm coming up, coming up, coming up, and bingo. This is where we have the lesser tuberosity. And right on top of that musculotendinous structure is your subscapularis muscle. And then on top of that is the thin muscle that you're seeing, which becomes a little thicker over here. That is the coracobrachialis, which is actually coracobrachialis, and anteriorly is the biceps muscle as well. But that is the fascial plane between the coracobrachialis and subscapularis that we're interested in. And medial is to the right of the screen. So our needle approach comes from lateral to medial. We're aiming for that fascial plane at 2 centimeters. We're aiming for the fascial plane, which is at 2 centimeters, and we will be splitting that fascial plane between the 2 muscle groups. So again, the top muscle is a pec major. The muscle below is the coracobrachialis, and then the muscle way below that is your subscapularis. And you can see just above the lesser tuberosity, you can see some, just above the lesser tuberosity, you can see that dark space. That is your shoulder joint. So you're not going to go there. This muscle over here, that is the fascial plane of interest. That is the fascial plane of interest. So that's where we're going to be injecting our local anesthetic with the goal of splitting this fascial plane and local anesthetics going more proximally. So that way you target the branches from axillary nerve, which are pre-articular. These are still not taken off from the nerve, so you're going to get a better analgesia to the shoulder joint. So that is the coracobrachialis subscapularis fascial plane block. So I'm going to conclude this over here. We're going to move on to our next scan. And for this, Dr. Gottlieb, we're going to have you come up and we will do an ankle block demonstration because that was requested. So ankle block is, thank you, Dr. Gottlieb. Okay, perfect. Yes. So ankle block, if you remember, we used to traditionally do it with, without the ultrasound, but it is so much fun to do with the ultrasound. There are 2 deep nerves. I'm going to start with those 2 deep nerves, and then there are 3 superficial nerves. And the first one, we're going to go for the posterior tibial. So the landmarks here are your Achilles tendon posteriorly, and anteriorly is your medial malleolus. But we're going to scan a little higher than that. So we're going to go above right here. And looking at the ultrasound picture, I'm going to reduce the depth. Okay, we are going to look for the pulsating vessel, which is right there in the center of the screen. That is the popliteal, the posterior tibial artery. And posterior to that, which is to the left over here, that is your posterior tibial nerve. So Right on top of that, you see that fascial plane. That is the flexor retinaculum of the foot. And the goal is you want to make sure that your local anesthetic is always below that fascial plane. So never go for the nerve. So what we do is we do an out-of-plane approach. We put a center line over here somewhere. You want to make sure they just pop through that fascial plane, start injecting. This is where you want to inject the largest volume because this is the biggest nerve of the foot. So we typically inject about 10 ml local anesthetic right here in this fascial plane. Next up is our second deep nerve, which is the deep peroneal, which is a branch of the common peroneal nerve. Landmarks for that is you will be looking for the shin, the edge of the tibia right here, and then right lateral to that, you're going to put your probe. And the things that we're going to look for here are your pulsating artery again. So right there in the center of the screen is your dorsalis pedis artery. And on below that is your tibia. And we're going to look for any nerve-like structure. Sometimes you see it, sometimes you don't see it. But the most important thing is as long as you go and touch the bone right next to, there's something, yeah, right there to the left of the nerve maybe. But even if you don't see it, if you go and touch the bone right next to the artery without, yeah, I can see the nerve right there.
Yep.
And there's some veins next to the artery as well. So if you let off your pressure, those veins will expand. See there? There's a vein right there to the right of the artery. Anyway, so go touch the bone, inject. I usually inject about 5 ml over here. So while we are here, let's start with the first superficial nerve. We're going to do this, the saphenous. Now, saphenous has a very close relationship with the saphenous vein. So I'm going to put the probe like right on top of our saphenous vein, which is very, very superficial in SAM right there. And the nerve, saphenous nerve, has a very, very close relationship with this vein. And again, sometimes you can spot this, sometimes you don't. I'm just scanning up to see if we can spot the nerve. But if not, you're just going to do, there is something to the left of that vein right there. And even if you don't see this, just do a little perivenous infiltration about 4 to 5 ml over here. That will give you medial foot analgesia. Okay, so we've done the first nerve, which is a medial to the foot. The next one we're going to do is lateral to the foot, which is the sural nerve. Now, the sural nerve has contributions coming up to the fifth toe. Sometimes it supplies the web space, last web space. Sometimes it supplies the web space before that as well. So it can have a variable contribution. So for this, you're going to put the probe right behind the lateral malleolus, okay? And now you're going to look for the lesser saphenous vein, okay? So we did that, a practice scan, and we were able to spot it on Dr. Gottlieb. It's a vein, obviously. So, okay, I think I can see a vein-like structure right there. So sometimes you're able to spot the sural nerve, sometimes not. I think I can see there's a yeah. Compressed. Okay, compressing, relaxing. There's a vein right there. So that's potentially the sural nerve. But then again, it's a subcutaneous tissue. So if you inject in that general area next to the vein, even if you don't see the nerve, you're going to have a successful sural nerve block. Okay, yeah, somewhere over there I can see a nerve-like structure. And then finally, my favorite is the superficial peroneal nerve. It used to be, when we did this block without the ultrasound, we would do like a very nice field block all around here, because the superficial peroneal nerve, it comes around here, but then it starts to branch off very, very quickly. So if you want to get all the branches, you have to go and do a field block. Now we don't have to do any of that. What you're going to do is go look for your fibula, which is right there, okay? On the screen, you see there's almost like a shark's fin, and the shark fin points to the nerve, and you can see the nerve is right there. That is your superficial peroneal nerve. And When I come south, when I come distal, you can see that a nerve starts to branch off very, very quickly in that fascial plane. You can see all these branches. So it's not really stylish or fancy to do it this far distal. Just come up here where it's nice and compact, inject 5 mL local anesthetic right around it in that area, and you will have a beautiful superficial peroneal nerve block. So here I conclude the ankle block. So to summarize, we did the posterior tibial, the deep peroneal, and we did the 3 superficial branches, the saphenous, the sural, as well as the superficial peroneal. So concluding this ankle block here, I would like to invite my colleague, Dr. Bryant Tran. He's an associate professor in anesthesiology, and he's part of our regional core group. And we're going to switch positions. And it has been a pleasure. And thank you, everyone.
Thanks, Monica. Pop in, Brian. So you're going to do paravertebral.
Yes.
What we're going to start with. And that was a request from somebody in the audience. Okay.
Well, I'd like to give a big thank you to everyone who's organized this meeting. I know it's a lot of effort to get everybody from all these different time zones on a weekend. And a special thanks to Dr. Grant for all his audio-visual expertise that's allowed us to do this.
So we've got Dan, one of our fellows. So UNC, we've got 3 regional anesthesia fellows, as well as being very competent regional anesthesiologists. They also double up as ultrasound models, which is fantastic. So I'm going to switch to our scan cam.
Okay, so the paravertebral block, I think, is something in an oldie but goodie. It's a block that I've seen in practice has been utilized less and less because of the popularity of the rector spinae plane block. But I think it is always something to keep in your arsenal. And also the ultrasound scans are so similar that if for some reason you are intending to do a paravertebral block but cannot find a good target, then you do have a couple of other options. And then so in my practice, for practicality and efficiency, I always tell myself that I want to do the things that are less critical, maybe a little bit faster, so that it gives me time when I actually do the procedure to have time to do it safely. So I'm visualizing here when I'm looking down before putting the ultrasound probe down where the midline is, and then approximately where the middle of the scapula is, visualizing the dermatomes that I'm intending to anesthetize. So if I put the probe where I imagine on the left side, so this is probably about 3 or 4 centimeters lateral to the midline around the level of the mid scapula. And so here I'm going to make some adjustments on the ultrasound image itself to increase the gain so that you can visualize the targets a little bit better. And then I'm going to increase the depth, 1 depth here. So I intentionally kind of scan laterally and medially, and this is a parasagittal approach. So if I'm scanning laterally here, I'm looking for very rounded structures of the bone, which indicate the rib. And then you can see the shining pleura below. And then I'll intentionally keep scanning medially until I see the bony landmarks drop, and then keep scanning medially until I see the contour of the bony structures are almost slanted like triangles. So here that's actually laminas. I've gone past there. So I know here is too medial and I can't really see a good paravertebral space. So the other thing practically clinically is that I want to see a good target before even deciding to proceed. So as I scan laterally here, I'm looking for a boxed bony structure, but I'm also looking for a good paravertebral target to put the local anesthetic safely. A lot of times we're also in a teaching institution, so you really want to err on the side of caution here. So as I'm scanning laterally here, I'm looking for a place where I can see the costotransverse ligament well. So scanning a little bit more laterally here.
You're looking in here for the costotransverse ligament. Yep.
Right. So if I hold the ultrasound probe there, I'm probably about 2 or 3 centimeters lateral to the midline, which would be appropriate to see the paravertebral space. And so the costotransverse ligament is looks to be a couple of millimeters above the pleura, which the pointer is indicating here. So you have a very little margin of error, which means that you really want to proceed as diligently and safely as possible. As far as the needle approach, this can either be done in plane or out of plane. So if you were to insert your needle, for example, in plane, you'd be going from cephalad to caudad, in which your approach would be to try to get right in the middle between the transverse processes. Alternatively, if you are wanting to go out of plane, you would shift your target towards right in the middle of the screen, and then essentially insert your needle where you would visualize where the middle of the screen is here. And then one last point here is that as when I consent my patients for a paravertebral, I also have in mind that if we can't safely place local anesthetic in the proper paravertebral space, that the other options would be to inject local in between the transverse processes, so middle injection between transverse processes, or MTP, or your erector spinae plane block, which would be right above the transverse processes, superficial to it. Okay, so that concludes our scanning on the paravertebral block.
One other thing was shown was, what the other one you looked at from the request earlier on? What's the second block you were going to show?
So the second block we were intending to show was how we do the adductor canal block.
Okay, let's lay Dan down and that falls on nicely from what we saw, what we've got coming next is an anatomical demonstration of adductor canal. So let's quickly show that. We'll do this as our final one, and then we'll head over. So Dan's automatically doing what he asks his patients to do. That's frog leg their leg. We usually have to ask the patients to do that. So
So we'll make left side lateral towards me, and when I look down, I'm visualizing where the mid thigh is. And so when I put the probe down, I am looking for the superficial femoral artery, and I may turn the gate down just a hair here. So needle approach would be in plane, and so left side would be lateral. So the view here, I can see the sartorius and the adductor muscle pretty well, and I can see part of the saphenous nerve, but I typically like to scan higher towards the thigh. So some would say this would be maybe perhaps more like a low femoral, but I'm kind of scanning higher and higher.
He's coming together here. Yeah.
So in this approach, I'm placing pressure on the leg so that the vein is compressed, but you can see the saphenous nerve to the left of the superficial femoral artery, and then the nerve to the vastus medialis is in this screen would be to the left of that. One thing I typically check is if I let go of pressure, I want to see where the vein is, and so I think with the person doing the block has a preference whether to be able to see the vein like this while placing the needle or compressing the vein. So Dr. Grant just pointed out some other nerve structures that we can anesthetize to reduce tourniquet pain.
Cutaneous branches on the top.
I've read them described on the internet as cuties.
That'd be that Jeff Gaffney. Yeah, ignore all the things he says. Haha. So yeah, but you can see those little branches nicely in our model here. Fantastic. So how much volume do you put in?
So that's a good question that a lot of people ask me. As when we first started doing these blocks, we wanted to keep the volume low for adductor blocks, so 10 to 15 milliliters or cc's, in order to avoid too much spread proximally to the femoral nerve. There has been some evidence, though, that you can inject a lot more volume before inducing clinically significant quad weakness. So, volumes as high as 25 to 30 cc's can be used, but you typically find that 20 cc's of local anesthetic is appropriate. Nerve stimulator with ultrasound has also become more popular with this approach, with the intent of stimulating the nerve to the vastus medialis, injecting about 10 cc's of local at that point, and then advancing towards the saphenous nerve and adding another 10. So this would be primarily for analgesia to the knee. All right, I think this concludes our scan for the adductor canal block.
Fantastic. I'm going to bring back our, oh, there we are. Got a right picture back. Raj, welcome back. I wish we'd more time to do one of these live scanning, and maybe if folks want it, we can work through another time, another Azure live stream. I want to thank our fellows here at UNC, and it's coming up that time. If you're interested in regional anesthesia, make sure you get your name in. Talking to all the residents out there, I know it's kind of a little bit less popular right now to do a fellowship. A lot more people going into practice, but oh my goodness, there's so many skills you'll get in a regional fellowship. So encourage folks to apply to get really, really slick at both the common and less popular blocks. It's going to make you stand out your ambulatory surgery center. It's going to make you stand out for inpatient pain management. It's going to make you the go-to guy or gal for lots of complex cases when general anesthesia would be really difficult for your patients. I find it rewarding. I mean, this is what this day's been about. It's been celebrating the people who manage people's pain. It's been celebrating their trainees. And I really want to thank again our colleagues at Ezra for getting this off and running. If we've inspired you, you want to see some good hands-on education, you want to see really good workshops, how to mix POCUS and regional anesthesia. Well, the spring meeting, Raj has already put the promo up. It's coming up in May the 1st to the 3rd. We're in Orlando this year. Sign up early. Don't be disappointed to leave at the last minute. Sign up early. Sign up for the workshops. We look to see you there. Little question: is the subscap auxiliary block published yet? It's in on the RAPM website right now, along with a link to a little video how-to as additional content. And Eleni, who's had a really long day, and in the bottom there, for those of you in the US that don't know her, Eleni is the president of Ezra, and this is Eleni's baby. It's her idea. Last year was great. This year has been phenomenal, the interest we've had. Next year, looking forward to it. So a fantastic, applause to Eleni and the Ezra team, and look forward to seeing all them soon.
Are we going to have to do 8 hours next year? Stuart, I think we're going to have to do like 8 or 10 hours. Oh
the marathon.
I feel bad. There's so many people we even left out, and last minute trying to get some people squeezed in here, but we thought it would be too much to do more. I don't know if people wanted to listen to us for 4 hours.
Raj, any conclusions at the end of the day before we go and sink into sofa?
Yeah, well, so we have one more video. I don't want people to log off. So we're going to kind of sign off, but we'll play one more video to finish off the live stream. I just want to thank everybody who participated, all the people that made time on a Saturday to come and present and be creative and be interesting and present topics that were maybe outside of our baseline knowledge base. And I think stuff that was applicable across the planet. I really, really want to thank everybody who watched live. And I mean, it really warms the heart to see such interest and excitement from across the planet, all across different continents. And I think that's fun and exciting to see. It makes it a joy to do this work. And of course, Stuart, thank you so much for helping put this all
thanks,
together.
Raj. Yeah. I'm looking forward to, you had a preview of this video. I've not had a chance to look over it. You told me
Yeah, this is cool. Yeah, they did a good job with this.
So these are our friends from Mayo Clinic who
Yeah.
we finished scanning the ductal canal, because if you're really interested in looking what the anatomy is about of that ductal canal scan, that's what we're going to show you right now.
So we're going to sign off. So as soon as the live stream, as soon as this video finishes, we'll finish the live stream. Thank you everybody for participating, and we'll see you at the ASRA Spring Meeting in Orlando.
Happy World Day.
Happy World Day, everyone.
Hello, everyone. My name is Adam Amundsen. I'm the Regional Anesthesia and Acute Pain Medicine Fellowship Director at the Mayo Clinic in Rochester, Minnesota.
I'm Beth Vanderwielen, the Associate Program Director for the RAPM Fellowship here at Mayo Clinic.
I'm Nirusha Lachman, and I'm the chair of the Department of Clinical Anatomy. Mayo Clinic is really fortunate to have a Department of Clinical Anatomy where we can partner with our physicians and bring you the best of anatomy related to your field.
And I am Antonio Rivera. I am a clinical anatomy fellow here at the Department of Clinical Anatomy.
And this is the second World Day of Regional Anesthesia and Acute Pain Medicine. We are in our clinical anatomy lab doing an adductor canal injection. We have our clinical anatomists that are going to do the dissection to see where the spread is of our methylene blue. So first thing I like to talk about is where the adductor canal is. And some people will describe this as the base of patella to ASAS and the halfway point. Some people describe that lower. I'm just going to start at that halfway point and see what we see for our anatomy. So this is a sonocyte ultrasound we're using. It's a high frequency linear probe. It's a 15 to 4 setting, megahertz. You'll notice that the indicator is on the left-hand side. That's anterolateral. There is the femur. Beth, if you want to point to that, there's your femur, the white shell. And then moving medially, we see the vastus medialis. Yeah. And as I kind of rotate, you'll see the sartorius. Beth, how do you like to describe the sartorius? A boat?
That's
Carrot?
I usually use the boat terminology.
I don't know if it looks like a boat or a canoe, or I'm not sure, but I think most of us like to call it a boat, and that's often the muscle structure that we're looking for. What's a little different of this fresh frozen cadaver is what, Beth? What are we missing in this? I think everyone can kind of sort it out, but what are we missing specifically here?
So the lumen of the superficial femoral artery is now collapsed just based on the specimen. So that's where this would typically be located. And then, of course, the femoral vein would be below it, which we don't see very well in this image.
Yeah, very hard to see a pulsating artery when, unfortunately, our specimen is no longer living, breathing. So one of the difficult things of doing injections when we're looking at specifically anatomy. Okay, so and then even more immediate to that, you'll see the adductor longus. Yeah, and let's scan. This is scanning up, so point to the adductor longus if you could, Beth, for us. There you go. Yeah.
Outline it here.
There you go, and you're seeing it's getting a little thicker as I'm scanning up. And then scanning back down, you notice the sartorius and the adductor longus. A lot of people describe this as being the sonographic landmark of when you're truly in the adductor canal. So right there as they kiss, want to point that out, Beth? Yeah, right there where they call it kissing. There you go. That's probably, some people like to call that the true adductor canal. When I'm doing my injections, I like a point within that 1 inch or so. I like to find the sartorius on the roof of the superficial femoral artery, and that's kind of the point where I like to do my injections. So again, point to the sartorius, Beth, if you could. Okay, now let's look at some of the neuroanatomy that we might be able to see. So some of the structures that we're hopefully going to be able to dissect out for you here today is the saphenous nerve and the nerve to the vastus medialis. So as I scan, why don't you point to the saphenous and I'll trace that. So this is going up the leg. So there you go, up the leg. Point again, Beth. There you go, yep. And let's go down the leg. Let's see if we can see it leaving the hiatus and going anterior to the superficial femoral artery. Go again, point again. Yep, there you go. And scanning again up, and it's starting to leave right there, starting to leave in the hiatus, okay? So scanning back to where we would do the injection, where we'd see the boat or sartorius on the roof of the adductor canal. There you go. And now let's point out to the nerve to the vastus medialis, a common structure that we like to actually get localized with local anesthetic when we do knee analgesia blocks, right? So once you find that nerve to the vastus medialis, I think we can all agree that that's what we are calling the nerve to the vastus medialis. Obviously, our clinical anatomist will be able to point that out later, or whether or not we're actually staining by doing a single injection in that adductor canal. So scanning up, you can still see that it nicely traces out, and then scanning down, still within that same proximity. Okay, now next step, we're going to actually do the injections, and then our clinical anatomists are going to then. All right, Beth, let's get this injection done.
Let's do it.
So what do you have in your syringe, Beth?
Currently, we just have a 0.5% bupivacaine plain, and this will just help us localize the space where we want to do the injectate. And then after that, I'm going to switch to our methylene blue dye. That's a mixture of methylene blue and our 0.5% bupivacaine plain.
Antonio, why did we choose that dye injection?
Well, we chose methylene blue because it's very good at staining nerves. It will help us during the dissection to identify all the small branches that we want to locate. And we also chose bupivacaine because it will improve the lipophilicity of the solution and will improve the nerve staining characteristics of it.
I love it. Hopefully I don't screw it up. So everyone out there, don't judge me. Here we go.
It's going to be great. Let's do it.
Yeah.
All right, let's talk about where we want to do it. So the halfway point, base patella, ASS, halfway here. It's about right here. What do you think, Beth? Do you want to, we could argue about the injection point of whether or not that's a couple centimeters, but I think a lot of us will agree with, the superficial femoral artery being in the middle of the sartorius. Now, how people like to inject in this space seems to be controversial, with some people like to go through the vastus medialis, and some people like to go through the sartorius. Me personally, I like to go through the sartorius. One of the reasons why is I want to make sure that I don't put my needle right through the nerve to the vastus medialis. So let's go ahead and get this done. I like to go right next to the probe for these very superficial injections. This will be an in-plane technique. Very superficial injection there. You can see my echogenic needle coming into the space. Should often feel a very distinct pop as you're going into that space. That looks pretty close. What do you think, Beth?
Yeah, I think that's looking great. That's excellent needlework. I love it. I'm going to give just a little bit of local here just to confirm the space. What do you think about that?
Oh, I love it there. When I let up on pressure, do you see that opening space there?
Yeah.
Let's give a little more. Okay, good. I think we should deploy the local anesthetic. You notice when I let up on pressure that we definitely got a lot better local spread into that area.
I'm going to switch now to our methylene blue injectate mixture. Again, this is 5 cc's of methylene blue, and it's mixed with 15 cc's of our 0.5% bupivacaine plain. And then our total injectate volume, though, is going to be limited to 15 cc's. Sure. I think that's what we most commonly use clinically.
Will you go ahead and hit record on the ultrasound?
Absolutely.
Good. I like it. Let's go ahead.
I'm starting to inject now.
It's very much filling that space. Love it. I love the echo contrast coming through the tip of the needle. That looks cool.
Yeah, it really does. And again, it's just a little different than what we see clinically, just because the superficial femoral artery naturally is just collapsed in a fresh frozen cadaver. But you can kind of see that over here on this part of the screen.
So I'm kind of rocking my needle, tilting back and forth just to see where our spread's going.
And so far, that's about 10 cc's of volume here. So I got about 5 more that we were planning to go.
We chose 15. I think we could arm wrestle over the exact volume too. Some people like 10, some people like 11, some people like 12. We kind of chose the middle ground of 15. Our leg here isn't extremely short stature. So I think 15, we'll see where, let's see what we get for dye spreading.
And you can almost see it sort of track back of here of what we think is the nerve to the vastus, which we will confirm clinically with our clinical anatomist dissection.
So once we finish the injection, I'll scan. And you know what? Let's relate our correlation, our sonographic correlation to what they see with our dye. How's that sound?
That sounds great. That's our total 15 cc volume. So let's go ahead and scan and see what we think.
Let's take the needle out. So this is where we did our injection. I'm going to first scan distally and see where we end up. It's probably the hiatus right there, don't you agree?
I do agree. I think that looks great.
So that's distally. That's probably, 3 inches, you know, or so from our injection point. Now let's scan proximally.
Oh, and look at how that saphenous nerve is highlighted so well now. And then back over here, our nerve to our vastus medialis.
Scanning up. Again, seeing a little contrast there. It's probably right there. What do you think? Stopping there?
Yeah, I would agree with that.
Again, another 3 inches. So 3 inches proximal, 3 inches distal.
Mm-hmm.
Now let's see what our clinical anatomists see with the dye, and I'm really looking forward to that.
Me too.
Okay.
Let's do it.
All right, team, let's summarize what we've done today. We performed an adductor canal injection with 15 cc's of methylene blue. Now, it's a debate whether that was in the adductor canal or in the low femoral triangle. It seemed to be coming right through the adductor canal for me, as we saw dye spreading right through the vastoadductor membrane. But let's take a peek to see what we actually saw in our findings, and let's summarize those things right now, okay?
Great. So as you can see in this anterior view of the thigh, here we have the anterior superior iliac spine, and we made an incision following the sartorius border all the way down to the medial aspect of the knee. So we will start reflecting our layers, and here we have the skin as well as the subcutaneous tissue. As well, on the other side, you can see the skin as well as the subcutaneous tissue of the thigh, as well as part of the deep fascia that is covering here, the fascia lata.
Yep.
So
there's a lot of blue there, isn't there?
A lot of blue in here.
Yeah.
So
now we debated over that total volume. We used, again, 15 milliliters. I definitely see a lot of blue. It's definitely staining a lot of structures there. We saw great spread sonographically. It seemed to be about 3.5, 4 inches proximal and distal to our injection point. So we're definitely seeing that clinically here. Yes.
Yeah, we can see actually stain in the more superficial plane, for example, the subcutaneous tissue, but as well you can see stain in the muscles, sartorius muscles, for example, as well as vastus medialis in here, and other structures such as nerves that we'll describe, and arteries and veins in here.
So let's start proximal at some of the neural structures that I think we all know, and then let's go distal and see what we see. How do you feel about that?
Excellent.
Okay.
Okay, so if we go proximal, we are looking to part of that femoral triangle.
Yeah, so let's talk about the femoral triangle. What are the borders, and what would you find there?
Okay, in here we can see the lateral border of the femoral triangle that will be this part of the sartorius muscle, this long muscle that is running from more proximal and laterally, crosses the thigh and gets more medially to attach inferior tibia. So this in here is the sartorius muscle. We can kind of appreciate in here the femoral ligament. In here, you can see that this structure in here is a femoral ligament that is going from this anterior superior iliac spine to the pubic tubercle in here. We are looking, we don't see in here very clear, I don't know if Dr. Rivera can tell in here, the medial border of the femoral triangle. I think more dissection.
It's really hard to identify the medial border. Just remember that it will be your adductor longus muscle.
Yeah.
And when it crosses with the sartorius muscle, that will be.
Yeah. There's definitely a lot of dye there that makes it a little more difficult to see what you're missing. Yeah.
We can kind of tell that probably it's this one in here, but there's a lot of dye in here too.
So then after the femoral triangle, you're going to go into the adductor canal. Is that correct?
Correct. And for that, we will see that the apex or the vertex of the femoral triangle will continue in the adductor canal.
Yes.
So
and you can still see a little bit of that light blue tissue there, that fascial plane right there.
Yeah.
That we cut through. It looked perforated, Antonio. What do you think of that?
We were talking about the membrane that's running from the vastus medialis towards the adductor manus muscle, and yeah, it looked like it was not a continuous sheet of fibrous tissue right there. It was kind of incomplete.
I thought so too.
That just left some of the spread going deep to that layer.
And superficial. You know, we see that with injections where it seems like some of the injectate's going above and some of it's going below, and you're wondering, gosh, how is that possible? And I think maybe that is how.
Yeah, and I don't think it's an uncommon thing that we see on ultrasound.
I think
either.
it's common.
So, yeah, I agree.
Okay.
It's quite interesting to see here.
Good.
Actually, you can see part of that sheath coming from the vastus medialis right there.
Yes.
And you can see how it is not a thick, complete sheath. You can see some very thin parts right there.
I agree. So let's look at one of the main structures that we're finding with an adductor canal block, which will be the superficial femoral artery. That would be a distal branch of the femoral artery, and note in the cadaver, or in this fresh frozen cadaver, obviously it's not going to have pulsations, which often makes it difficult when you're dissecting out. So if you could show us that, that'd be great.
And here we have that artery in here, and we know that this is the artery because we see the characteristics of the wall. So this is thicker,
yes,
and it's more, we can tell a little bit more anterior in here, and will be passing through the adductor canal in here.
So the veins underneath it, which again, that makes sense sonographically, we often see that.
Yes, so this will be the femoral vein in here, as you can tell, this one in here. And we can see another important structure, and this structure is also passing through the canal, but then it exits in some point more medially in the thigh, the canal, that is the saphenous nerve in here.
So saphenous nerve, yeah.
Yes, so this is piercing through that membrane that we mentioned before. So in here we see that saphenous nerve in
So
here.
it looks like it's running lateral to medial around the artery. Is that, would you describe it as that?
Correct.
Yeah,
So
okay.
it follows the same path as the other two structures there.
So definitely I see stain there. What do you think, Beth?
I agree. And maybe we can just pick up the saphenous nerve a little bit and sort of zoom in with our camera. You can see the very deep blue staining sort of in the heart of the saphenous nerve as it would extend throughout the entire canal. And then also as it's exiting the canal, you really don't see much staining distally either.
I don't see it. I do not see it staining distally. No, I do not.
Correct.
I agree with you. Then one of the other big structures we talk about, we debate about, is the nerve to the vastus medialis. Let's find that structure.
So in here we can appreciate in here that nerve to the vastus medialis. And here we see the vastus medialis, and this nerve that is coming from the femoral nerve in here.
Yeah, it looks like it's branching there. Is that?
It's branching.
So there's two
all the way
branches
down.
of it all the way down.
Yes.
It looked like that's what I was seeing sonographically. Did you?
Agree. Yeah, and actually, admittedly, I sometimes do see that on ultrasound in patients just clinically, and I always sort of wondered a little bit about that.
Sure.
So here
And they could be right next to each other. Here, obviously, they're separated.
Yeah.
We've dissected the area out, so you might see some distance between them. But again, sonographically, they're probably right next to each other. And do you agree that they're stained?
I would agree. And then I also think it might be nice to just point out, if we look a little bit more proximal to the femoral nerve, kind of the heart of the femoral nerve itself, we do not see that staining tracking proximal.
You know, you made a great point about the actual, how would you describe it? The curvature of the leg and how the nerves are coming out. It almost looks like the nerves are running in a bowl. You see that? And the local would have to actually run up the bowl to the femoral nerve. If, you know, you'd have to push the volume up the bowl in order to stain it. So it's something I didn't appreciate until I'm actually like here dissecting it out. That, yeah, I definitely, I saw your point there. Yeah, I like it.
Yeah. I would agree. There is quite a profound sort of slope to it.
I think the point I was making, it'd be tough to stain the true femoral nerve proximal, as you would have to run it up against. Yeah.
Yeah, and also you can see how in the femoral triangle, where you can see the femoral nerve in here, there is a lot of adipose tissue that we needed to remove in order to appreciate in here the femoral nerve. So
I like it. Good. Any concluding points, Beth?
You know, I think it was quite interesting to see sort of the total length of spread that we had from a 15 cc injection, that we definitely got the saphenous nerve quite profoundly highlighted with our methylene blue, as well as we have two branches from the nerve to the vastus medialis that were both stained quite nicely. And we did not notably see any staining proximal to the femoral nerve. And likewise, we didn't see any very distal staining, though, as the saphenous nerve was sort of exiting more towards the knee. Our injectate very clearly stayed proximal to that.
I concur with you 1,000%. Should have we used 15 milliliters? What do you think?
You know, I think for our dissection purposes today, I think 15 cc's was the right volume because we use it so much clinically, and it does make you question whether or not that truly is the right volume, and if we should cut down on that during our procedures for our blocks before patients go to the operating room. But I think for our purposes, it gives you sort of an idea what 15 cc's can do, and maybe yet to come, we'll have to trial lower volumes and see if we get such profound spread.
Wonderful. I think this was very educational for myself. Hopefully it was very educational for everyone here. Thank you to our clinical anatomists. I profoundly enjoyed my time here. Happy Second World Day for everyone. What a great event. Happy to support and just thank you.
Thanks everyone for tuning in.
Thank you.